Safe and effective care. So under safe and effective care, you have two subcategories. One of them is management of care, coordinated care, and safety and infection control. Today is all about management of care and coordinated care. Next time we will do safety and infection control. Okay, so this area tests you on your knowledge that keeps the client safe. It doesn't test you on your knowledge of disease processes, on specialty areas, no, okay? Just how to safeguard the client physically and non-physically, right? So let's start from the beginning, from the top. We're talking management, who's in charge, who leads, who makes rules, who makes policies. So starting from the top is your Nurse Practice Act. So every state has a scope of practice that is governed by the state. So some of you are not in Florida, but most of us, I believe, are in Florida. But I think some of you are in Texas, some of you are even in Canada, some of you maybe in New York, but every state has a state board of nursing. Every state does, okay? Now, every state has passed these laws to regulate how we nurses practice. But it's not just us, you know, they have policies for the assistive personnel, LPNs, RNs, nurse practitioners, right? Okay, so they set the scope of practice. They set the educational standards. They're the ones who say, okay, if you're giving an associate degree, you need to have that. If you're giving a bachelor's degree, length of time, all of that, right? They're also the ones when we're negligent, which we're going to talk about in a moment. That is a vocabulary word that you need to have under your belt. When we are negligent, they're the ones who also take away licenses and set punishment and consequences to whatever it is you did wrong. Okay, so professionally speaking, professional misconduct. Okay, negligence, impaired nursing, we're going to talk about. There are boundaries that are set. When nurses violate those, license gets stripped away. Yep, that's what we're talking about. In addition to your state board of nursing, we also have standards of practice. So standard of practice is established by the nursing profession, the American Nursing Association, ANA, you've heard of them. They define our specific responsibilities, okay? Plus the National League of Nursing, the LNL. Try saying that fast, LNL. NLN, we gotta say that slow. But in addition to the Board of Nursing, the American Nursing Association, the National League of Nursing, there is the standard of care. The one that's most important for you and I that are practicing at the bedside, that have clients that we're responsible for, the most important one to know, the others are important too, but the one that's going to keep you from getting sued is the standard of care. That's what's most important in my opinion. The standard of care. So now the standard of care is the care that is instituted by your institution. So you go work for hospital ABC, nursing home DEF, urgent care ZYX, whatever facility you go work for in the United States, they have been accredited by an accrediting body. For example, Joint Commission. So our institutions here in the United States are governed by these governing bodies, whether it be ACA, Joint Commission, whatever it is, whether it be a hospital, urgent care, home health, you name it. They have these standards that they have to meet before they open their doors, before they touch a client, before they cut their ribbon, whatever it is. They have a set of standard, a standard of care that they say, okay, Joint Commission, we have these standards where we're going to do that. Now, when you get hired by that institution, you need to know those standards of care. You need to know what the protocols are. You need to know these things, because once you're following these protocols set by the institution that was approved by their accrediting body, if, God forbid, your client dies, I'm not saying that's okay. I'm saying that they can't sue you because you were in compliance. And there's even such a thing for the public. We're going to talk about the Good Samaritan law. That's another great example where you're protected as long as you stay within your scope of practice. So same thing here. You work for hospital ABC, the client comes in having a heart attack, you followed your protocol that is set for a heart attack, and God forbids the client dies, you cannot get sued. They can try, but as long as you were within your standard of care, you're fine. So those are the type of information we're going to talk about as well. So that's your standard of care. It's institutionalized. You follow it. Here's a question to jog your mind. And I'm looking for answers. I'm looking for people to chime in. Please. The LPN has been asked by the physician to perform a task that the nurse believes is outside of the scope of practice for that LPN. We're going to talk about the RN scope, the PN scope, the AP. They don't really have a scope, but we're going to talk about everybody's responsibility, because part of this section, a nice, lovely little topic that falls under this umbrella is delegation. So you've got to know that in and out. And those are high-level questions. So I'm going to make sure you're good before we end today. Who would the nurse contact in order to get the proper determination of whether the task may be performed by the LPN? So the LPN has been asked to perform a task by the physician that she believes is outside, or he is outside of their scope of practice. Who would verify that? Is it the State Board of Nursing, your coworker, your director of nursing, or your nurse educator? Throw me some answers. I don't move forward until I see you chiming with me. And the sooner you chime with me, the better, because I have a lot to cover and I want to make sure I get everything done before our time goes out. And with this system that we use with Webinar Jam, it cuts us off at 4 hours. Like, it doesn't play. It doesn't give us 4 hours in 1 second. It cuts off in 4 hours. And I don't see any answers yet. Let me reconnect. Okay. Thank you, Gladys. Thank you. All right. So yes, the State Board of Nursing would be the one, but you get it. Those are the type of questions that would be phrased from that area. All right. So you're good with that one. Next topic. Chain of command. Your test tests you to see that you know how to follow your chain of command. This is an important one. This is professionalism they're testing, okay, because our field mandates that, okay? So let's take this to a nursing school setting. By the way, don't always think your questions are gonna come from the hospital setting. Yeah, that's the majority of the setting, but there is home health, there's outpatient clinics, there's the patient's house, there's the community, there's the patient's front yard, there's the nursing school, there's the grocery store. Like, your question can be anywhere, okay? Pay attention. That's a test-taking strategy and tip right here. You do a question and you see there's a setting, they put the client somewhere, or else, we just say you have a client. But if I put them somewhere, community, outpatient, ICU, NIC, whatever it is, pay attention. Where is that client? So I'm just giving you an example here, and I'm taking the client to a home health agency, right? So now you have a client in home health. So let's say, actually, no, nursing school. This is a much better, that's an NCLEX question too, floating on the NCLEX, a nursing school. So isn't that crazy? I'm taking your client to a nursing school, because sometimes you think, is that a sick person? No, I told you this section doesn't deal a lot with the dead and dying. It deals with leadership. So you're in nursing school and you have a conflict with your instructor. How do you handle that? You need to talk to the instructor. So now let's take it back to the hospital. You're having a conflict with your colleague who works next to you. You need to address it with your colleague. Now, if it's not being addressed, you're not getting resolution, you go up the chain. So with the nursing school, you have an ADON. If you have an ADON, an associate director of nursing, you need to go to your associate director of nursing. If it's not being resolved, then you go to your director of nursing. If it's not being resolved, then you go to the dean. It depends on, the chain of command that they have set. It's not being resolved with the dean, you go to the campus president. You don't just have an issue. Imagine you have an issue with your teacher, your instructor, your professor, and you call the owner of the college. That's crazy. You jump so many chains. It is not professional. So let's take this back to the hospital. Something is happening on your unit. You see one colleague does something and you're not able to resolve it with them. You need to go to your manager. Now, if your manager is not able to resolve it, you climb the chain. Okay? So on this picture here, let me see if you can see my cursor. Give me a second. I want to, yes, you can see my cursor. Awesome. So here where I have, start with the LPN. So above the LPN is the RN. Above the RN is the charge nurse. Above the charge nurse is the interim. Above the interim, the resident. You get the point. So this is where we're going to be focusing because that's us right here. So, LPNs report to the RN. We're going to go over scope of practice. RNs report to the charge nurse. The charge nurse report to the interim nurse, like that. And you need to follow that. Okay, here's another one on the right-hand side, the hierarchy of nursing. You go from the bottom up. All our hierarchies look like triangles and they go from the bottom up. Maslow's hierarchy, we went over that before, from the bottom up. Your Bloom's taxonomy, from the bottom up. So you have your PN, then your RN, then your nurse manager or educator or nurse practitioner, and then you have your director of nursing all the way up to the CNO. Okay, so that's the chain of command. Keep that in mind. Here's an example. The nurse observes a staff member from the hospital laboratory take jewelry from a client's bedside. Which action by the nurse is best? The word best tells you this is a high level application type of question. So although it might be easy now because you know how to answer them, but they're high level questions, which is great. Do you want, throw me some answers while I read these, contact the supervisor of the hospital laboratory? 2, confront the staff member and say, I saw you. Okay, first of all, we do tell you read all of your answers, but you can feel that one is not correct because that is just not going to help anything. You're confronting and you're saying something that's a bit aggressive, right? That's not good. Number 3, report the situation to the nurse's supervisor. Tell the client that the staff member took the money. What is that going to solve, right? All right, so the answer is report the situation to the nurse's supervisor. The nurse observes. So you're going to go to your supervisor. Okay? Now, the supervisor of the hospital lab is not your supervisor. You need to go to your supervisor. Awesome. I see everybody's good and on the same page. Okay, next topic. QIQA, or quality and safety, or QSIN. There's so many different terms for this. My area, I love quality. I think quality saves life. That's just my opinion, and I've actually seen it save life, so it's a fact for me. So every institution here in the United States is required to have a quality department. Thank God. So quality departments, and you see in the full name, quality and safety. Woo, yay. They are patient-centered because this test is testing to make sure that you're safe and you're patient-centered. Remember, I told you it's not about you. It's about the client. It's teamwork and it involves collaboration. So what do I mean by that? This department requires or mandates you to have a collaborative team. You've heard of the multidisciplinary. So whatever skill you provide, you need one of those representatives in that team. So for example, if you provide nursing skill, you need an RN, you need a PN, right? If you provide PTOTST, you need those folks to represent. You provide physical therapy and there's no physical therapist as part of that team, that doesn't even make any sense. You provide speech therapy and there's no speech therapist as part of this team, Who speaks on their behalf, right? Who says, no, that's not our policy? Who does that? You need one of those individuals. It's evidence-based practice, right? What's working out there, that there's evidence that it works. And part of that is monitoring outcome. Okay, so we made changes. How do we know it's working? And safety's in the middle of that. Now, informatics is kind of penetrating everywhere, right? Information and technology, because that's just the realm we're heading to. Don't fight it. I remember when, this was a long time ago, when Broward General was deviating to electronic Mars, everything electronic. There were so many nurses who just had mini heart attacks and tantrums, but what choice did they have? Those who hate computers, you need to learn to love it. You need to dive in, figure it out, because that's where we're heading. My goodness, it truly is. So embrace it so you can be really good at it. And although, human touch will always be needed, but it makes life a lot easier, quicker, and we get things done a lot faster. And the millennials that are coming up are so connected. I'll give you an example. So just even yesterday, my husband was working on something with my son. There's a test he has to take. And my husband says, get pen and paper to take some notes. He says, why? I'll just screenshot it. I loved it. I was like, oh. So that's kind of the realm we're heading. I have another son, my 12-year-old. He can hear me from here. He asked Siri to do so much. But that's just the realm we're in. As long as they're reading and writing, fine. I don't have a problem with that. If the technology helps you do it quicker, faster, and go for it. So that's the, information and technology is just part of who we are now. So embrace it. Oh, you had that question on NCLEX. Let me go back. That's exciting. This one, the nurse observed a staff member from the hospital lab. That was your question? Don't tell anybody, okay? So I have some really, really good stuff. I'm just going to say that. And then we'll leave it at that so I don't get in trouble. That is, students tell me that all the time. So we're just going to keep that our secret. I love it though. I know. And that is why you need to practice my questions. I know you have like other resources. I'm not saying don't use them because you've already purchased them and they work, right? Use them. If you purchase UWorld, use it. If you purchase Kaplan, use it. It's not the products. There's nothing wrong with the products. Just learn how to use them best. What benchmark are they asking for? How they're phrasing their question. I'm never going to deviate you from that, but do practice the questions I have at the end of my PowerPoints. Do practice the questions that I'm sending your way because I know why I'm throwing those at you. This is pretty cool. I love that. All right. Performance improvement, quality assurance. So recap. They focus on the safety. Safety is at the center. You know that already. Everything we do is for the safety, the best, for the client. It includes the total organization. It's multidisciplinary. So this is recap of what we just talked about. Okay. I like to do that because it sticks to your long-term memory. Okay. Next topic. So part of what we do, or this section, is called management of care, coordinated care, right? So part of being a good manager or coordinator of care is to learn how to prioritize. If we don't learn how to prioritize properly, we cannot provide safe care or care that, takes care of what's important first. So we need to learn to prioritize. This is part of this area. So prioritizing involves deciding which needs or problems to take care of first. Hence some of our question, what's the first thing, the best thing, the initial thing, the priority thing, right? So what do we take care of first and what do we delay? Okay, and life is like that. I know we're talking nursing and NCLEX and all of that, yes, but this is life. Can you imagine if you, for example, you have a household to run. Okay, here's a great example. So you're running your household and you decide you're just gonna go ahead and pay for the electricity bill and the cable, but not the mortgage. That doesn't even make any sense. What's the point of paying for the electricity and the cable if you're going to lose the house? So life mandates priority, right? Life mandates priority. Those of you, who have religious backgrounds, God, family, career, right? Can you imagine if you put the career before the family, you lose the family? Like, life is just not worth it at that point. So there's priorities in life. We haven't talked about this word, but it makes sense to bring it here right now, and you will hear me talk about this word over and over again. It's a word called homeostasis. Okay, in life, you need that balance. Okay, so we're going to talk about homeostasis again. But this is part of it. You need to prioritize. So, and Klex throws this at you to see, can you prioritize? And those are nice high-level questions. You want them. Okay, you want them. You want to be very good at them. You want to get them right. You get another one type of thing. Okay, so how do you tell what to do first and what to do last? Okay, so we need to assess needs that are life-threatening, that could result in harm to the client, versus those that are not life-threatening, that can be put to the back. We need to be able to tell what's actual and what's potential. What is happening right here, right now that I need to intervene, and what's a maybe, maybe not. Might happen, might not happen. Okay, so the nursing process plays a role with this. Maslow's hierarchy plays a role with this. Okay, so we're gonna get into that. Here's an example. The nurse enters the room of a client diagnosed with depression. The nurse finds the client non-responsive, with a bottle of pills lying on the floor. What is the nursing priority at this time? So this is test taking strategy, right? Remember, we already talked about priority. I have issues, so I'm going to put a question mark right here. All right. So the word priority tells you this is a nice high-level question, right? And it also tells us, remember, we went over our test-taking strategy, so just recap, because I think some of you may be joining me for the first time. So whenever you get questions where you see what's the first thing, the best thing, the initial thing, the priority thing, those are high-level priority questions, the word priority is in it. So the nursing process is the first step. So, well, second step. First step is to ID what type of question you have. And this type of question is a priority question. Okay, step 2 is the nursing process. The nursing process tells us we always, and remember, always is a absolute word, okay? You need to be careful with words like that, but that's the truth right here. We always assess first. That's true. But be careful when you see words like always, forever, every. Those are called absolutes, and you have to be like, is that every? Is that really all? Is that really always, forever and ever till infinity and beyond? Like, you have to ask yourself when you see words like that. But in the example that I'm giving you, yes, we always assess first. Okay? So we have to ask ourselves, have we assessed? So let's go back to the question. Our clients are diagnosed with depression. We walk into the room, we find them unresponsive with a bottle next to them. Have we assessed? So answer me, everyone. Have I assessed this client? And that's the first step. You have to be able to tell whether you have or haven't in your question. Because if you can't correctly go past that section, everything else is just going to fall apart. Diagnosed with depression, the nurse finds the client non-responsive with a bottle of pills on the floor. Have you assessed, everyone? Talk to me. I know we know the answer, but have we assessed? Oh, okay. The answer is no, we haven't assessed. So step 2 is a no, we haven't assessed. So the nursing process tells us we need to be doing an assessment. So measuring the vitals is an assessment. It's going to give us numbers. Number 2 is an implementation. Number 3 is an implementation. Number 4 is an implementation. So just those steps alone gets you to the correct answer. Okay? But if you go through the rest of these answers, you can do that, but that's not priority. You can check the chart, but that's just not priority. the others are just not priority. And whenever you see words like that, you know there's going to be some other things here you're going to do, but there may not be priority. You need to find the priority thing to do. So that's a priority question. And we are talking about establishing priorities. So when you get these questions, they're great. You want to get them correct, but also apply the nursing process, apply Maslow. So if we had more than one answer left, next step would be Maslow's hierarchy. And Maslow says physical needs first. So everything that's psychosocial would be thrown out because you would not do them first. Okay? Great question. Here's another one. A nurse working on the medical unit arrives at work 15 minutes late. The nurse is assigned 5 clients and an admission is on the way. Place in order of priority how the nurse should complete the following activities at the beginning of the shift. So this is a put in the right order. Place in the order of priorities how the nurse should complete the. I'm going to give you about 30 seconds to do this one. 30 seconds. Okay, maybe 35. And then we're going to talk because there's a lot to learn with this one. Throw me some answers. Let me see your answers. Awesome. Y'all are awesome. Yes. So we're going to listen to report first. Okay. Then we're going to check on the status of all the clients. That makes sense because God forbid one of them may not be breathing. Then we're going to do the lab. Why are we doing the lab before the MAR? Because depending on the client's lab, there are some medications you may not need to administer. Okay. Let's say their lab work was done and they were hypokalemic and now they're hyperkalemic. You may have to hold the potassium. You see what I'm saying? So that makes sense. So this is you showing that you can prioritize. Okay, let's read the rationale, but normally I leave you to read that later because it eats time and I want time to cover a lot. The nurse should start the day by listening to report. Yep, this allows the nurse to receive information about the status of each client. The next action is to check the clients. The nurse should check on each assigned client to determine his or her current status and assure they are not in distress. Next, the nurse should review AM labs to obtain pertinent information to help plan the day and detect subtle changes in the client's status, which allows early treatment and preventative interventions. Lastly, the nurse should review the MAR to detect priority medication. The lab results can impact the medication given. That is why you need to check the labs before you check the MAR. So when you're doing questions on your own, oh, by the way, if I didn't mention this before, I want to mention it now. Right now, as we're learning, see what questions, how the questions are generated from the material and how to go about answering questions, you're going to be practicing questions. And when you practice questions, the source that you're using, if you're able to put it in practice mode, I would do that because practice modes means question, answer, question, answer, question, answer, like that. Don't put it in a testing mode yet because you're learning. So what you would do is you would do the question and then you would see whether you're correct and you would read the rationale. Even when you're right, I would love for you to read the rationale. Because a lot of time we just read the rationale to the stuff that we have wrong. But when you read the rationale to stuff that you have right, especially if you guessed, right? If you guessed the answer, definitely read the rationale. Because this is where learning takes place. Because you might have gotten this correct, but you didn't know or fully grasped why you want to do the lab before you do the MAR. But now you do. And if I were to flip this question and just ask you to choose one answer or select all out of, like, you'd be fine because you know the why. Remember, we talked about that. Every time you pick an answer and everything, you want to know why. So we're building critical thinking at that point. You're building the understanding behind it. So that's how you study. You're gonna study in a study mode. You're gonna do questions in a study mode. Question, answer, question, answer, question, answer, like that. Okay? And that's how I have the questions for you at the end. That's how I have them for you in the different PowerPoints. And the NCLEX 4000 is like that. And I believe, I'm certain that Kaplan, you were like, they have this study mode, question, answer as well. So do it that way. All right, any questions so far? We're going into a new topic, which is communication. That's another big one, folks. There's so many different angles to this one, and you want to be well versed here, okay? Even leadership style falls under this arena. All right, if you have any questions, let me know. And don't forget, you can raise your hand as well. But when we pause after, like, right before we break in everything, we can do the speaker. All right, so communication skills and conflict. So one of the first things you want to assess when it comes to communication, whether you're communicating with a client, a colleague, you're communicating up, you're communicating down, you're communicating laterally, diagonally, doesn't matter. One of the first things you want to do is assess, right? The nursing process follows us wherever we go, is assess. What are you assessing? You are assessing the other person's perception to receive. Think about it. If they're not ready to receive whatever it is you want to communicate, and vice versa, somebody may be communicating something with you where you just don't want to hear it. So there needs to be an assessment of a perception to receive. For example, you go into the room, you want to teach Mrs. Jones about how to self-inject insulin. However, Mrs. Jones has back pain. Do you think she's going to be ready to listen to you with her back pain? No. Take care of the pain, then she may be interested. So it's silly stuff like that, right? You need to assess and be ready, especially when you're trying to make changes. Whenever you're trying to make changes, you want to make sure people are ready to perceive, you want to unlock, you want to tell them why the change is necessary. You know, otherwise, folks may not even be listening to. Let's say you're a charge nurse on your unit and you want to make changes to something pertaining to your unit and your floor. But nobody's listening. You need to tell them why this change needs to happen. Then maybe they might listen, especially if it affects everybody on the unit, it affects financial, it affects bonuses, then people may be open to listen, but assess and make sure they're ready to listen. We're also going to talk about conflict, how to handle that, how to prevent conflict. We talked about chain of command, which is a bit of a part of that. Okay, leadership style. So, and we're also going to talk about patients with disabilities and how do we communicate with them as well. So you see how there's different angles to this one? All right, here's the first one, telephone orders. So give me one sec. I thought I added some more pictures to this one. All right, telephone orders. So the moment you're taking a telephone order, you need to understand that it should be written immediately, literally while the physician is in your ear. You need to be writing that order, okay? And of course, you're gonna sign it. The order has to state clearly. We don't do TO anymore. You know that. We do telephone order, like you write out the entire. You must read it back. Joint Commission says you must read it back, okay? And then once you read it back, you sign it, it's effective. The physician can come the next day, whenever they do rounds, and sign it. You can implement it. You can give whatever it is, do whatever it is. Okay, and then it must be co-signed. Whatever time limit that your floor, your unit, your organization has, that differs from facility to facility. So you won't get questioned on that, like the exact time. Okay, because one hospital may say this amount of time, another hospital gives you another time frame. Don't forget, your exam is across jurisdiction. So unless it's the same at every hospital in every state, you don't get questioned on it, okay? So here are some examples. The drug order written by the physician, it has 7 essential parts before you can administer it. So this is a proper order right here. It needs to have the client's full name, the date, the drug's name, the dosage, the route, and the frequency, time and frequency you need to give it. Is it daily? Is it every other day? Is it when needed? And then it must be signed. So all of this component needs to be there in order for this medication to be correct. And here's another example for you of a prescription. I love that when I found this little example. As you can see here, all those components that I just mentioned are here. And this right here, the one that says take 1 tablet by mouth every day, this is important. Remember, we don't do the Q-day or QD anymore. We don't do the Q or D anymore. We have to write it out. Take 1 tablet by mouth every day. That whole PO thing is out the window because so many mistakes used to happen. People weren't sure what was being written, what was being said, and overdosing was happening. Oh, this is I like this little picture because it kind of covers it all. Okay, so patient's full name, Patricia Pearson. I found this online, it was great. The date is there, the drug's name right here, atorvastatin. Now, the suffix statin, what drug is this? What family? Statin. While you chime in and talk to me, let me keep going. Atorvastatin, calcium, 20 milligram tablet. We went over this one. Take 1 tablet by mouth every day. Even, you know, with the pharmacy, how many refills. And I love this. Avoid consuming grapefruit or grapefruit juice while on this medication. If you're pregnant, all of those little good stuff are there. This is a statin. What family is this? Just the suffix alone, tell me what type of drug this is. Ooh. No, try again. It's not a CC blocker. Statin. Atorvastatin. I bet you know the brand name. It's the generic name that you need to work on, but you know the brand name. I have a document for you on Riggs and Plex that has these little prefix and suffix specifically for medications. And these are on there with the suffixes. When we do pharm, I'll go over it. Yeah, these are, somebody just put it, are the anti-lipids. They lower the bad cholesterol. But you're more familiar with Lipitor, Zocor, Crestor because of the brand name, but this is Lipitor. So statin alone tells me what family. So when you get a chance, we're not there yet, but if you need to start working on that, there's a document with all the suffixes. It's like a little cheat sheet with the drugs. So take a look at that, but that's not what this section is about. This is about a proper medication order, okay? Now, we're still in communication. When we take clients, give clients, receive clients, send clients off, we communicate, right? And we have a standardized, meaning you go to New York, it's gonna be the same. You go to Canada, you wherever, there's a standardized framework for communicating between members of a healthcare team. It's called the S-bar technique, okay? The S, the B, the A, and the R stand for something, okay? So S stands for situation. Tell me what the problem, right? What happened? Background, some information related to this situation. Assessment, I need some most recent vitals, right? What was found? Recommendation, you're sending this person to me, okay, what is it that you want me to do? Right? You're going from med-surg to ICU. Okay, what's the situation? All right, this is Mrs. Jones. She was on our unit, newly diagnosed with HIV. All of a sudden, some decreased respiration, some palpitation, you know, and then the physician felt the need, okay, they need higher acuity. Okay, background. I gave you a little bit of background. They were just diagnosed, you know, with HIV, and assessment. Give me those latest vitals. What were the respiration? What were you hearing? What were, the pulse, the blood pressure, all of that? What medications are they on? And what's recommended, So I need that little piece of information. You don't need a whole full history because they get the chart and everything. This is just to hand this off to them. And you would do the same thing if they're going to a nursing home, coming back. Like we all do that. It's handoff. You need that. Okay. Another one is called I Pass the Baton. A lot more detail with that one. All right. Another topic, leadership style. You do need to keep those in mind. And I know some of like your resources has even more styles. These are the most prominent ones, the most important ones. So authoritarian is also called autocratic, the first one right here. If you have somebody with this leadership style, you need to know how to best utilize them. And that's how the questions are phrased, right? This type of leader, they're the ones who are great at giving direction. That's their behavior. They have this directive behavior. They are awesome for emergencies. You have mass casualties. These are the folks that are great in the ER. They decide alone. They focus on the task. They get it done. They get it done yesterday. Okay. And they go on to the next, right? They give orders. You do this, you do that. Get back to me in 30 minutes and don't be late. Like that's them. They don't fraternize with you. They don't ask your opinion. They don't care either unless it's going to get the job done. I don't want to know. So that's your authoritarian, also known as autocratic. Same thing. The next ones are the democrats. Those are the ones who are open to communicating with you. They're the ones who ask your opinion. They're great if there's no emergency, right? Monday morning meeting, coffee, donuts, tell me your opinion. They focus on people. They care about your opinion. They're not good for emergencies. Okay, don't put them in the ER. Laissez-faire are the worst. These folks accomplish nothing. They don't care. They're passive. You walk into the room, you don't know who's in charge, and they don't even care that not good in emergency. Your bureaucratics are not good in emergency either. They're the ones, they don't decide unless they see it in black and white. They need to see it in writing. What's your policy? What's your procedure? What's your rules? What's set in place? Let me see it. They're very insecure. They know the rules and they want to follow the rules. Okay. So you do need to know so that you as a leader who to assign where, right? Another NCLEX question, which is under this umbrella as well, is a very unique one. The best leader, by the way, is the one that can change their style based on the need. You don't always want an authoritarian. Sometimes there's no emergencies. We just need to chill, right? You don't always want a democratic because sometimes there's emergencies and we need somebody to be in charge. The one that can change their style is the best. And it makes sense to me. All right. Next topic, floating nurse questions. I love those. I like that little picture too. All right, you have a postpartum unit nurse. Postpartum unit nurse is assigned to care for a client on the oncology unit. Which assignment is most appropriate for the postpartum unit nurse? Now, the way you answer floating nurse questions is number one, pay attention to what type of nurse he or she is. Because if you don't process that, you'll give them the wrong client. What type of nurse is this? This is a postpartum nurse. They know about babies being born, how to care for the mother after the baby's born, postpartum. They may be, very familiar with hemorrhaging. Postpartum or priorities hemorrhaging. So you got to process all of that. Right? Are you throwing answers at me yet? No. Okay, so stop throwing some answers at me. And there's still a lot more to learn with this one. I thought maybe you were throwing some answers already. Okay, so paying attention to what type of nurse this is step one. It's priority, okay? So now you need to look at your 4 clients and who's the best person to give this client to. But in addition to all of that, let's talk about floating in general. So a nurse is a nurse is a nurse is a nurse. Doesn't matter where they float to. They can, for example, RNs, right? RN can take on admissions because they're an RN. They can take on, the med-surg stuff, well trained in that. They may not be trained in the specialty area. So you want to give, them the most stable, predictable type of clients. But pay attention again as to what type of nurse. Because, for example, if the nurse is an ER nurse, they ought to be able to handle the most critical clients, right? So that's why the first rule with floating nurses is what type of a nurse are they? And this person is going into an oncology unit. So you want to stay away from giving them unit-specific client because they don't know jack about cancer, right? And they're going to a cancer unit. So keep all the cancer people. They don't know anything about those. So you have a 64-year-old with a prostatectomy. After prostatectomy, you have a 54-year-old diagnosed with lung cancer and bone metastasis. You have a 40-year-old woman diagnosed with ovarian cancer, receiving cyclophosphamide cancer drug that this postpartum person knows nothing about. A 34-year-old woman with positive breast biopsy scheduled for surgery that day. So you have to ask yourself, which one here is not a unit-specific problem? Yes, one is not a unit-specific problem. The others are unit-specific problem. Cancer, breast biopsy. So you have to ask yourself, where are they coming from? What type of a nurse are they? This is a postpartum nurse. She should be able to handle this condition with no problem. But the unit-specific stuff, okay? So that's how you think about those. Now let's cover communication with clients with disabilities, okay? So sometimes you have clients who have hearing loss. You have clients who have speech impediment, okay, aphasia, your post-stroke clients, your dementia clients. So how do we communicate with them? Let's talk about your hearing loss people first. Your hearing loss, first of all, the findings with them are very unique. Okay, they're usually socially withdrawn, they're suspicious, they speak loudly because they can't hear you. They think you're talking about them. Whenever they're talking to people, can you say that again? Can you repeat? So at times they withdraw because of all of that. You're calling them, they don't respond, so they present special ways, right? How do we, the healthcare providers, intervene? Okay, so you're dealing with a hearing impaired client. First of all, there's a safety tag attached to this. Whenever you have conditions that have safety components attached to it, they're priority. I'll give you an example. So I went to get blood work the other day at my primary care physician. And in the middle, I had to do a full physical and everything. In the middle of all of, she just did an EKG. The fire alarm in the hospital goes off. This was at Memorial Miramar, the doctor's offices, aside from the hospital. Literally, the fire alarm goes off. It's loud. So the nurses come out and say, is this a drill? Is this a drill? And then they were told, no, it was not a drill. So everybody had to exit the hospital. There were hundreds of people out in the parking lot. So the hearing impaired people would not hear that. So the hospital is mandated to put those lights, right? That flicker, flicker, flicker. So we have to accommodate. So you two have to accommodate. You have to speak slow. You need to face them. They read your lips, okay? Clear, short sentences, low tone. You see how if you're listening to me, my tone goes up and down because that's naturally me. I'm not monotone at all. Sometimes it sounds like I'm screaming because I get excited and I want to make my point. The monotone is better for these people. So when I'm dealing with a hearing impaired individual, because I've done that where I used to do home visits all the time and I would visit the elderly. First of all, the moment I get there, I'm looking for their hearing aid for them because that just helps me. But I had to get to a monotone with them because the high pitched stuff doesn't work. So as I enter the home, I keep my voice, at a range and kept that range the whole time. That's hard for me to do, y'all. I'm just saying. So, but you have to do that for them. Turn off the TV, stop the children, and we've been drilling in you all throughout nursing school. Stay away from closed-ended questions. Stay away from closed-ended questions. This is the exception to the rule. This is the client where you want to ask closed-ended question where it's a yes or no, simple, right? And this is opposite of what we've been telling you, but there are exceptions to these rules, and this is one of them. Okay, so you have to know how to communicate with them. Throughout my PowerPoints, I have these little funny graphics. I try to keep it fun. It's a lot of material. Turn up your hearing aid, he said. Your money or your life, not your money or your wife. So instead of giving up the money, he chose to give up the wife. That is so funny. That's terrible though. Give up the money, not the wife. I guess it depends on the wife, right? He has hearing problems. All right, let's focus. Post a CVA. So you have clients with strokes. So you know when you have a right hemispheric stroke, your left side is impaired, and vice versa. When you have a left hemispheric stroke, your right side is impaired. So let's give this client a right hemispheric stroke, right? So they've had a right hemispheric stroke. So then they're visually impaired to the left, right? So you want to always approach them to the right. That's their good side. Tell them, turn your head all the way around to see the room. They're the ones, when you move their stuff, you put it back where you took it. Because they just go to grab it and it's not there. They fall. It's your fault, right? Explain to them where stuff are, right? They're the ones when you give them their meals because they can't see properly. You want to use the clock. Your chicken is at noon. Your mashed potato is at 3 because everybody gets that, right? That's why you want to do that. I'm going to put a clock right there in the future. I think I might have one in one of those PowerPoints. Repeat and reinforce, re-instruct, tell them free, like all of that because of the problem and the disability. Your dementia clients, remember, they're always confused, right? The moment they remember you, the next moment, who are you, dear? Okay, so we're always calm with them. We're never rushing. That's another thing I have to do purposefully because I'm generally fast-paced. So when I deal with anyone with, with dementia and Alzheimer's and everything, I kind of need to adjust. I need to readjust myself. I can't, expect them to know. Don't ask them to make decisions because you really cause anxiety, right? Be consistent. They're the ones who need that consistent schedule. Every day we do that at 9 o'clock, 10 o'clock, we do this, and every day is the same thing. Don't change it on them. And we frequently reorient them to person, place, and time. And it does take a special nurse to be in these arenas. It really does. And in this field, in this session, when you're dealing with the elderly confused, it does take a special person. It does take a person who's patient, right? Who has a lot of love because they need it. They married it versus, a middle-aged us who can walk and talk and that, It does take a special person to be in this area. So hats off to those nurses. Kudos. All right, aphasia. So post a stroke, a lot of clients suffer from aphasia. It's a communication disorder, okay? That's from the damage from that part of the brain that causes them to not understand speech, to not understand written words, to not be able to articulate their own speech. So these are vocabulary words right here. You need to know these vocabulary words, okay? You know me in the vocabulary words because you could have a question and you are not able to answer it because you don't know the meaning of these vocabulary words. Wernicke's aphasia is the inability for the client to understand spoken and written words. So if they are diagnosed with Wernicke's aphasia, you, the nurse, walk into the room and say, "Good morning, Mrs. Jones." They don't understand that. You might as well walk into the room and say, blah, 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 blah. All right? They don't understand that. Same thing. Don't give them a magazine. They cannot read written words. They don't understand written words. That's Wernicke's. Broca's is the opposite. They can't get it out. They can't speak it or say it. That is expressive aphasia. So with expressive, the person knows what he or she wants to say, yet they have difficulty saying it. I shared with you before, my mother has several strokes. The last one left her with Broca's aphasia. So I went to go see her yesterday. Was it yesterday? Yeah, the kids and I went to go see her. And she was trying to tell me, well, it's so funny. My sister that is her caretaker, the second sister, She knows her so well and knows what she wants to say. I don't. And she was trying to say. I'm like, man, I'm guessing. And finally, my sister figured it out. But that's because they spend so much time together, you know. But she has Broca's aphasia, and she has a hard time all the time trying to get the words out. But these are vocabulary. Global aphasia is a combination. It's very severe. They have both. They don't understand you. They can't get the words out. They can't read it. How do you communicate with this individual? It's very, very difficult. So you have to be creative and when you communicate with them. Throughout the PowerPoint, you're gonna see little mnemonics, little things like this, the 4 C's of communication. You must be clear, concise, correct, and complete. We're going to talk about delegation. That is a part that needs to take place. You're giving somebody direction to, you know, perform a skill or something. You need to be clear. You need to be concise. What is exactly that you want? Okay, you need to be correct and you need to be complete. Okay, does the delegatee have all of the information they need to perform the task? Okay, and are you following policy and procedure? You're giving the CNA direction to walk Mrs. Jones down the hall. You need to be specific. If Mrs. Jones gets tired or out of breath, please sit her down, you know, and walk her halfway down the hall and bring her, like, I want some specific directions on what it is that you want done. We're going to talk about delegation because remember, if it doesn't go right, it's your fault. You're still responsible. All right, next topic. Well, this is still under communication, okay? Next subtopic, dealing with conflict. So you're tested, both RN and LPN, on how to handle conflict. You have 2 colleagues that are arguing and not getting along, and they're doing it at the nurse's station. Big no-no, right? But for some reason, these questions, whether it be New World Kaplan, they put this mess at the nurse's station. Take prompt action, okay? You're working with both parties. Okay, you're going to be objective. You're going to meet with both parties at the same time, okay? And you're going to bring in a third person that has nothing to do with the craziness. Meet with both parties at the same time and bring a third party that has because if you meet with one and not the other, they're going to think you take sides, right? So you need to be careful how you handle these and handle it as soon as possible, okay? Because the longer you let stuff deviate, people make stuff up in their minds. All right, next subtopic, case management. So this still falls under this umbrella, but it's a little bit unique. Case management is a little bit unique. I know we know, okay, we're the nurse. However, in addition to being the nurse, we wear other hats that we don't have degrees to wear, right? You're not a case manager, but it is your job to make sure that, you know, these things are done. Like, for example, the client is being discharged. It is your job to make sure that resources are available in the home. For example, if the client is now chair-bound, it is your job to make sure that, you know, they are going home with a wheelchair, there's a ramp to access the home, you know, all of that. Let's say they're going home and they're newly diagnosed with COPD, they need to be on a breathing treatment. It's your job to make sure that there's, you know, the machines are at the home, the incentive parameter is there, like all this stuff is already there. Wounds, they go home and they have to care for wound. It is your job to make sure that the wound care supplies are there before the home health nurse goes to take care of the wound. Like all of that is us, right? So you're going to explore that. You're going to assess the need for any of what I just mentioned. Oh, I love this one right here. You are cost effective right here. I've got to highlight this. You are cost effective. There are so many questions where I've seen students get this wrong because they're not cost effective. You don't waste money. You find ways to save money. Now, not at the cost of infecting the client, not at the cost of safety, but you're cost effective. Don't waste stuff when you don't have to. Okay? So, you know, all of our care is individualized because no client is the same, so no care plan should be the same. We need to make sure we do proper discharging so that they don't end up coming back. And the care plan is being updated continually. Okay. All right. So we're done with that section. Any questions so far? Because we're going into a really important one and then we'll take a break. Delegation. Delegation is key. Like, you want to be so good at this section. And I think this is one of those sections. Priority is another one. Priority and delegation under the management of care. I think once you get those two down pat, like these students that I find to be really good with these sections, they get the minimum questions and they pass. Like, I really do think that those two areas, but I don't know, you know what I mean? Like, that's just my sense from all the studies and research and going to these meetings, that I'm getting the sense that these two areas, priority and delegation, ooh. So wake up. If you're sleeping, wake up. And you shouldn't be sleeping. All right. So delegation, let's go there. And this is the area where I go over everybody's scope of practice. So you definitely need to wake up and understand exactly what's under everybody's scope of practice. No matter if you're a PN or an RN, you need to know your scope and the scope of the person on top of you, below you, next to you, all over. Okay. So this is a great picture to me because he's the king, right? Why is the king doing that? You have to delegate, right? There are some things that you need to do, and there are some things that somebody else needs to do and not you. Oh, a student asked me a really nice question the other day, and I thought this was interesting. Let's talk about it first, and then we'll do the question. I know some of you started to do the question. No, go back. Let me share this with you first. This is so important. So she was practicing from UWorld. And she said, so her question was, you have a LPN, you have an RN and LPN in the AP, assistive personnel, on the unit, and what task should you delegate to the RN? And select all that apply. She chose the vitals, continuing vitals, and that was wrong. And she was like, why? Because the nurse can do it, yes, but the question was asking you, what would you delegate to the RN? That task can be delegated to the assistive personnel. So you got to pay attention to these questions. Yeah, the RN can do it, yes, but if she does that, what is the AP gonna do? So we're gonna practice those questions. You're going to be very good at them, and you're never gonna get any of them wrong ever, ever, ever again. All right. I decree and declare that. All right. A nurse is assigned to a facility for the first time. It is most important for the charge nurse to take which action? All right. Nurse assigned to your facility for the first time, most important. First of all, the word most tells you this is a priority question. So I need you to think of the nursing process. Okay? And I promise you every time, even though this is a delegation question, but because of the word most, I know for sure I need to apply the nursing process. Assess the nurse's knowledge and skills. Assign a resource person to work with the temporary staff. Contact the nursing supervisor to see. Assign the more acute clients to the floor. Okay, so look at this. Assess. Implementation, implementation, implementation. You haven't assessed. So the answer is an assessment. And you're assessing the right thing. Yeah, because if you know her skills and her knowledge, you know what to assign her. Do you see how easy these things are? Once you know that, apply it every time. I see the word most, I'm like, okay, this is a priority type of question. Boom, step one. Step two, nursing process. Assess, implement, implement, implement. Have I assessed? No. Get rid of everything else. It is that simple, okay? But this is a delegation question. So we're gonna get into delegation. All right. So delegation is the process of transferring your responsibility and authority to another person, okay, for the purpose of performing a task. There are rights to delegation. You're going to see that in a moment. There are principles to delegation. We're going to talk about that. It is a voluntary contractual agreement. We're going to talk about activities in patients that the RN can never, ever delegate, and the PN can never, ever accept. Okay? We're going to talk about the LPN's responsibility and scope, the AP's responsibility. They don't have a scope. Evaluate and review, and then we're going to do the nursing process. Okay? So with evaluation, or evaluate the ability of the staff member to perform assigned tasks, part of that is their job description, their scope we're going to talk about, their skills checklist. Okay, you saw the question before, this one. We want to acknowledge her skill level. Yeah, that's part of this. Before you delegate, you should know what they can and cannot do. And let's go to an NCLEX question. So you delegate to a PN on a wet to dry dressing, and they've never done one before. So the answer is for you to do it, show them, and then check them off. So now next time you don't tell me you don't know, because I know you know, because I did it with you, right? Here are your 5 rights, and they make sense. You need to delegate the right task under the right circumstance to the right person with the right direction and communication, which we just talked about, with the right supervision and evaluation. Okay, so you go over that again. Now, imagine your different roles as an umbrella or a ladder. A ladder is better. So at the top of the ladder, even at the top of the nurse practitioner, you have the physician, right? You have the physician, the nurse practitioner, then the RN, then the PN. Then you have the assistive personnel. That's all the CNAs, HHAs, techs, whatever your hospital calls them. Under NCLEX umbrella, we call them APs. They used to be called UAP. So if you're using a book or a source that says unlicensed assistive personnel, UAP, that's fine, because they just recently changed that term. So that doesn't mean your source is old, okay? But if you're using most recent up-to-date resources, you'll see AP, which is the same thing as a UAP, okay? I don't know why they changed it. All right, RNs, what is the scope of practice of the RN? The scope of practice of the professional nurse includes the performance of those acts requiring substantial specialized knowledge, judgment, nursing skills upon applied principles of psychological, biological, physical. In other words, all that you learn in nursing school. And a big part of what you learned in nursing school was the nursing process. The help, teaching, counseling of the ill, injured, and or, check this out, observation, assessment, nursing diagnosis, planning, intervention. Isn't that the nursing process? That's the nursing process. Okay. In addition to that, medication administration, including IV push, okay, or intravenous medication, chemo, blood, TPN, fluid, all of it falls under the RN umbrella. Okay. A professional nurse is responsible and accountable for making decisions that are based upon the individual education. So yeah, all that you learn in nursing school. So the scope of practice of the RN tells us that we're doing, all parts of the nursing process. I'm going to show you where the PN comes in. PN, you're going to need to pay attention to that, right? So RNs, we assess, we teach, we evaluate, we do all admissions. Right here. I need to bold that. I need to highlight it. I don't know what else I can do with it here. Yep, all. Okay. So keep that in mind. All admissions and discharge. Not some, not part, a percent, all. But do you see how it says here? We perform most We perform most assessment. I forget every time I click on here, it takes me to the next one. Okay, that is because the PN does ongoing assessment, unstable, predictable, nothing's gonna happen client. All right? So RNs perform most assessments, but admit all new clients. So you know the new admission assessment we're gonna do, but we don't need to do ongoing assessment, unstable, predictable clients. We do all discharges. We care, RNs, you care for all complex clients. You care and keep for all the difficult clients. Okay. So yeah, you're not delegating those. Recap. So the RN cannot delegate. You know the little mnemonic, don't delegate what you eat, right? You've heard of that one. RNs cannot delegate new assessments, evaluations of client data, nursing judgment, education, discharge, like you kind of get the point. So that's all the recaps for the RN. I recap it again. So now let's talk about PNs. Now, we RNs, we do have a limit to our scope. Let me go back and show you something. Remember my little ladder? So let's start from the top down. So the physician, they don't really have a limit to their scope, right? They can prescribe, from prescribing to changing the bedpan. They can do all of that. ARNPs, nurse practitioners, they're limited. There are certain medications they cannot prescribe. Every state differs with that. There's still a fight going on with that. RNs, we're limited. We cannot prescribe. LPNs, you're limited. And when it comes to the nursing process, the care plan and medication administration, we're going to talk about that, your scope. And the APs have no scope, right? So this is the thing. You can always delegate down because you can do everything under your scope and the scope of the person underneath you. Because remember, you cannot delegate something you cannot do yourself, right? That's why the PN wouldn't be able to delegate IV push because they can't do IV push. RNs wouldn't be able to delegate medication prescriptions because they can't prescribe, right? So you can delegate what's under your scope and the scope of everybody underneath you. So that's why the physicians can do it all. They don't change the bedpan, but they can. And that's the lowest, right? And remember, an AP cannot delegate to another AP. So you can delegate down, you cannot delegate up. One more time. You can delegate down, but you cannot delegate up. And that is why you need to have that ladder in your mind with APs at the bottom, PNs are next, RNs are next, nurse practitioners are next, physicians are next. You need to know that. You can delegate down, you cannot delegate up, okay? Now, let's go back to the scope of the PN. PNs care for stable, predictable clients. The client with hypertension for 40 years, diabetes for 30 years, right? They're stable, they're predictable. We know nothing's gonna happen. They're not unstable. They're not unpredictable. So PNs assist with the implementation of a defined care plan that's been set by the RN. The PN is not putting together the care plan. PNs perform procedures according to protocol, differentiate normal from abnormal, has knowledge of asepsis dressing change. So they can get all of those questions, right, about sterile, right, asepsis, which we'll talk about when we do infection control. Now, here's the caveat for PNs, and we're gonna dig into this a little bit more. The ability to administer medication varies with educational background and State Nurse Practice Act. So this is where the state caps PNs. So the scope of practice for the practical nurse includes the performance of selected acts, which includes the administration of treatments and medication, in the care of ill, injured, and infirm, to the promotion of wellness, maintenance of health, and prevention of illness under the direction of a registered nurse, a licensed physician, a licensed or osteopathic physician, a licensed podiatrist, or licensed dentist. So PNs have to be under the umbrella of the RN up, right? You can't have a PN be the primary care person. Like on the unit years ago, when I first started at Broward General, we had RNs and PNs wouldn't be able to just take a load on their own. They would always be under the umbrella of the RN, right? Always. So that's rule number one that you need to keep in mind, okay? Now, some states, the PN can get certified in IV infusion. Certain LPNs who have demonstrated competency and institutional approval may also administer intravenous therapy under the direct supervision of the registered nurse. So they can, like antibiotics, not a problem, right? But here is where it gets complicated. Aspects of intravenous therapy which are outside of the scope of the licensed practical nurse, unless under the direct supervision of the registered nurse or physician, and which shall not be performed or initiated by the LPN without direct supervision, including the following. So no PN can initiate blood or blood product, chemotherapy, plasma expanders, investigational drugs, mixing IV solutions, IV pushes, except heparinizing or flushing a line. Any questions with this? Just the other day, I'm going to talk about this in a minute. I did a class for a school. I'm doing a capstone course for them, and I went over this in detail. And this young man came up to me and said, nobody ever told me the scope of practice of the PN. They just told me that they can't do as much as the RN. But he's like, thank you so much for going into details, you know, with this so that they know now. But that's how it should have been done when you were in school. Okay, so the PNs can do oral meds, IM, sub-Q, they can change dressing, they can irrigate wounds, they can monitor IV flow rate, right? Monitor. You want to see words like that. Ongoing assessment, monitoring, assisting. They can suction. They can teach basic hygiene and nutritional measures, right? So you see how we say RNs do all the teaching, but this is basic hygiene. Okay, basic hygiene, everybody can teach that. Urinary catheter, use nursing process. So the nursing process, they're not putting the care plan together, right? But they can use the nursing process to better care for the client. So that's the PN. Now let's do the AP and then we'll take a break, promise. So the assistive personnel. Let me go to this and then I'm going to come right back. The assistive personnel, they do standard unchanging procedures. Okay, so all these terms are the same thing. So whether they call a nursing aide, a tech, CNA, CHA, whatever, they're all assistive personnel, and they used to have the unlicensed there. They assist with the direct patient care, the bathing, the transferring. Don't forget they can do Accu-checks, the guaiac test. Those are some of the things that students ask sometimes. They can feed via a peg tube, not a problem. They ambulate, bathe, transport, room, range of motion, specimen collection, okay? So that's the AP. Couple questions and then we break. A new nurse graduate is reassigned to a medical surgical unit. Which of the following assignments is the most appropriate? So, a new nurse graduate. Question for you. Does a nurse graduate have a license? I'm looking over here to see if you throw some answers at me. A new nurse graduate. Does the new nurse graduate have a license? Throw me some answers. No. So then they're an assistive personnel. So rephrase this question. What can you delegate to the assistive personnel? A client with diabetes who is going home. There's some teaching. A client who has a diagnosis of chest pain. A client with frequent seizure activities. A client with dementia who is confused. Yeah, a diploma is not a license. I hear you. But the question is there a license to lose? No. So then they're an assistive personnel. Okay, that's what you have to ask yourself. So what can I delegate here to the, or who can I delegate here to the assistive personnel? Going home requires teaching. Chest pain, you're keeping that diagnosed. Frequent seizures, my. So it's the dementia who's confused, not the frequent seizures. Yeah, because you're going to need to intervene for those frequent seizures. So with the confusion, they just need to reorient them frequently. Here's another one. An assisted personnel is assigned to a medical surgical unit. Which of the following assignments is appropriate to delegate to the assisted personnel? Changing a surgical dressing, stop there. That's outside of their scope. They don't have the scope for that. Tracheostomy care on a client with a new tracheostomy? No. Ambulating a confused client around the unit? Hold on. Assisting a client newly diagnosed with stroke with a meal? Your keyword here, how you're omitting it, newly diagnosed with a stroke. So you want to hold on. Okay, so let's go. Let me see. Yep, I see 4. Let's talk about this one. You would not delegate 4 because of this word, newly diagnosed with a stroke. The ambulating is fine. But because they're newly diagnosed with a stroke, the RN needs to keep that client in case they aspirate, right? Awesome. Let's try one more. The delivery of care system on a medical floor is team nursing. On wing A, there's a registered nurse and a licensed practical nurse to care for 8 clients. Which task should the RN perform? Select all that apply. Now, this is one of those great questions. You have an RN, you have a PN. So some of this will be for the RN, some of it will be for the PN, and they may sometimes throw stuff in there for the AP, right? I can change this question and put the assisted personnel in there as well. Or I could change the stem of the question and say, which would you delegate to the PN? So you've got to pay attention to details here. So we're delegating to the RN, and then we are going to do this. We're going to switch this to the PN so you can see both angles. So would I delegate? Let me give you a moment first. Throw some answers at me. So which ones would you delegate to the RN? Let's do the RN first. So talk to me, everyone. Which task here would you give the RN? And then we'll talk about the PN. Let me refresh. Okay, I see some answers. So vital signs and assessment on a post-op client, yes, because they're post-op, right? That's a keyword. They're just coming from surgery. Wound care and oral medication, that can go to the PN. They can do wound care and they can do oral medication. Sorry about that. Vitals and bed bath on all 8 clients. The RN could be doing better things. Examine and assess on 2 young stable clients. Yes. Administration of IV push. IV push, right? That's your keyword. I'm looking at your answers on this side. Yes, okay, perfect. So let's recap. The RN, vitals and assessment on post-op, they're just coming to your unit. You need to be the one to do that assessment, right? And those vitals. The wound and oral can be given to the PN. The vital signs and bed baths on all 8 clients, especially if it's ongoing, you can delegate that to somebody else. Exam and assess, RN, IV push, RN. So now, if I were to change this RN to PN, it would be 2. What else? That's it. Because you can give the vitals and the bed baths to the AP if I add an AP to this question, assisted personnel. So you see how I can change this? Let's try another one. Am I frozen? Okay, I thought I was frozen. A nurse is preparing for a long day on a medical floor. The nurse has many tasks to complete. Which task must be performed by the RN? And then we're going to change this to the PN, just so you'll see. So, RN, irrigate a nasogastric tube on a client who has had a colectomy. Flush a clogged urinary catheter on a geriatric client. Recheck vital signs on a 30-year-old asymptomatic client with a BP of 100/60. Change the dressing on a client with an infective diabetic foot ulcer. Administer blood product to a client with an HH of 10 and 25. So this is the RN. Throw me some answers and then I'm going to talk to you. Irrigate a nasogastric tube on a client who had a colectomy? Yes, because they had a colectomy. The RNs, you want to be keeping that. Let me refresh to see your answers. Oh, I don't see any answers yet, unless that's from me. I think that's from the other question. Flush a clogged urinary catheter on a geriatric client. You can delegate that. Rechecking the vitals. You can delegate that. Change a dressing. That PN can do that. It's just a foot ulcer. Administer blood product. RN needs to keep that. So the RN is going to keep 1 and 5. If we change this to PN, you can give the PN 2, you can give the PN 3, and you can give the PN 4. And if you have an AP with you, you can give the AP 3. Asymptomatic is a nice keyword. Yep, just 1 and 5. And you see the rationale here? I just told it to you verbally. The scope of practice of the LPN allows them to flush. Where's my cursor? Oh, come on. Okay, I don't see my cursor. Allows them to flush Foley catheters and change dressing. Blood administration, you know, the RN is keeping. The PN are allowed to irrigate nasogastric tube, but in this case, the client had a colectomy. And because they had a colectomy, there could be some complications. Okay, all right. So we are resuming with the nursing process, which I told you is super, super important. So you know the nursing process, we have that little mnemonic, ADPI, or little acronyms, ADPIE, and you know A stands for assessment, D for nursing diagnose, and not just diagnose. It's important to state here nursing diagnose, because we're going to talk about the difference between physician diagnose and nursing diagnose. And it's important to know the difference, because you never want to step outside of, okay, making sure I can hear myself. You never want to step outside of your nursing diagnose, because if you do that, then you're outside of your scope. So it's important to know the difference between medical and nursing diagnose. And we're gonna go over that. Then there's the planning, implementation, evaluation, and there's some stuff that I'm teaching you about each area, and we're going to practice different types of questions that deal with different parts of the nursing process, and then we'll talk about some stuff concerning diagnosis. Okay, so you know the very first step, the very first domino is assessment. You must complete an assessment before you can analyze, plan, implement, evaluate. It makes sense, right? We've talked about it, and that's why they use this to make your test. What's the first thing? An assessment. What's the best thing? An assessment. What's the initial thing? An assessment. Yeah. And it makes sense. But an assessment is just collecting data. That's all it is. But that data tells us what to do. Based on the data that we receive, we know what we should, or what the problem is first, what we should plan, how we should implement, and what we're evaluating. So it's just data collection. Okay, an assessment, whether it be from the client, from your physical assessment, from objective, subjective, but you're gathering data. Once you gather data, you have to validate it. Is it true data? Especially, I'm going to drill this again when we do mental health psychiatric nursing, because subjective data that you get from mentally ill clients are not correct, right? You have to validate them. You have to make sure they're true. So after you validate information and making sure it's correct, you need to organize it. And you know, everything we do it in an organized fashion, right? we put it in priority order. You saw that earlier. They test you to see that you can prioritize, okay? And then we can implement, okay, something. But until you do all of that, it's just crazy. So after we organize the information, we interpret the information, then we document. That's always the last thing, always the last thing. So after assessment is diagnose. That's the second part, nursing diagnose. Okay, how do we formulate a nursing diagnose? How do we come up with the problem based on the information we've gathered from this client? So one of the first things we always need before we can come up with a nursing diagnosis is the physician diagnose. You see they do this in your questions, right? The client is diagnosed with nephrolithiasis. The client is diagnosed with postpartum hemorrhaging. The client is diagnosed with stroke, right? You usually get the diagnose, the physician diagnose, the medical diagnose. From the medical diagnose is where our nursing diagnose generates from. Okay, and I'm going to show you that. So nursing diagnose is a clinical judgment about the individual, family, community responses to actual or potential life-threatening problem. What has the client been diagnosed with by the physician? So that nursing diagnosis provides the basis for our nursing intervention. So we can't intervene until we know what the problem is. We can't know what the problem is until we assess. So that's like a backwards, right? So now, here's the big difference between medical and nursing diagnosis. So the medical diagnosis is the physician identifying the threat, the problem with this client. Okay, they're licensed to do it, they're qualified to do it. Us, we identify the situation that the nurse is licensed, we're qualified to do, right? And I'm going to show you what that is. So next slide. So here, the physician focuses on the illness, right? The stroke, the COPD, the hemorrhaging, whatever it is, the physician focuses on the illness. We, nurses, focus on the response to the illness. Okay, so for example, the other thing you need to remember as well, the medical diagnosis remains consistent. If Mrs. Jones is diagnosed with COPD, she's got that diagnosis for life. Rarely do diagnoses change. One I can think of from the top of my head is preeclampsia and eclampsia. So a client's preeclamptic state may change to eclamptic if they have the seizure, but rarely do medical diagnoses change. That was just, a rare one. Us, our nursing diagnosis changes all the time. As the client gets better, we are resolving, then the diagnosis change. So for example, the physician diagnoses Mrs. Jones with breast cancer. That remains constant. She's gonna have that diagnosis for life. But when we assess Mrs. Jones, we see that she doesn't know anything about cancer or breast cancer, so we give her knowledge deficit. Oh dear, what am I gonna do? Does that mean I'm gonna die? That is powerlessness. She starts to cry. Am I gonna have my breast taken away? Oh my God, if they're young and they think about, the image and everything, yeah, you're gonna give them that diagnosis. If they have a hard time coping with this, then ineffective individual coping. You see how we're looking at how she's responding to this diagnosis? So that's how we come up with our nursing diagnosis. So let's say, I'm playing with this. Let's say the physician diagnosed Mrs. Jones with COPD, cerebrovascular, appendectomy, amputation, strep throat. So we're looking at all of that. COPD, ineffective breathing pattern, stroke, activity intolerance, appendectomy, pain, amputation, body image, strep throat, body temperature risk for altered. However, once I get all of these nursing diagnoses, I have to prioritize them. So I want you to help me prioritize this. Out of all of these nursing diagnoses, which one should I address first? Obviously, it's the breathing pattern, right? Because of airway, breathing, circulation, Maslow's physical needs versus psychosocial needs. And if I were to rearrange this, I would switch these two, right? I would take the strep throat and put it here and put the stroke here, right? Because physical needs take priority over psychosocial needs. That makes more sense. And if you were to go even further, the image disturbance and the appendectomy, those are psychosocial. That's psychosocial pain. That's not even safety. So you can move this and have these two switch places if you're going to prioritize this. Does that make sense, everyone? Because psychosocial needs are last. The body image is psychosocial. If you don't address it, they're not going to die. The pain from an appendectomy is psychosocial pain. It's not physical pain. We talked about pain already. This isn't pain where they're going to lose a body part of their lives. So you must reorganize and prioritize your nursing diagnosis. What's first? What's best? What's initial? And then Maslow's hierarchy, physical needs before psychosocial needs. Let's practice the question to make sure you understand. That's how I know whether you get it or not, right? So be ready to chime with me. 4 post-operative clients are admitted to the medical surgical floor. After receiving report, which client would the nurse see first? So with the nursing process, are priority type of questions. We saw those earlier. And you see why I tell you these two sections are so important. They're intertwined with each other. So who do you see first? A client with vital signs of temperature 99.4, BP of 134/74, pulse of 84, respiration of 18 in 24 hours post an appendectomy. Those are beautiful vitals. There better be a worse client here than that. 2, a client 24 hours post-abdominal surgery with abdominal tenderness. Okay, that's expected. You just had abdominal surgery. You're supposed to feel something. Mild abdominal distension. We like words like mild. Small amount of serous ingredients. Small amount. We like that. Let's hope there's a worse client here for us to see. Number 3, a client 8 hours post realignment and splinting of the fractured left tibia, who reports severe pain and has weak palpable pulse on that extremity. Hold on to that one, right? Severe pain, weak palpable pulse. There's a circulation problem. So unless I have an airway, I'm holding onto that client, right? Unless I have a breathing problem, I'm holding onto that client, because so far, that's the first client I should see between 1 and 2. 3 is priority. Let's see number 4. A client 4 hours post-transurethral prostatectomy, receiving continuous bladder irrigation with 2,000 ml pink urinary drainage with occasional small clots. That is normal, that's expected. So number 3 would be the first client you see. So if you were to start from the beginning, you read this question, the moment you see which client will the nurse see first, that type of question is a who do you see first, or what client do you see first? The way you answer those is going through all the clients and saying who's stable and who's unstable. You can't answer this client using the priority skills. It just doesn't work. Not until you get to ABC. Because this isn't a nursing process type of question. It's a stable versus unstable. Number 1, 2, and 4 are stable. There's nothing wrong with them. Number 3 is unstable. But now let's say you have more than one client left that okay, both of them are unstable. Let's say you have 2 unstable clients. After you do stable versus unstable, you need to look at what's actually happening versus potential to happen. And if you still have, actually before that ABC, but we don't have that. I have some examples coming up for you because I want you to see it. And I want you to be able to tell this is an airway problem. This is a breathing problem. This is a circulation problem. So we're going to practice this so you can see them. I can tell you verbally, but it's good for you to see it. Okay? And that's what's coming up. ABC. So we went over ABC before. I told you airways, anything that impedes that oxygen from getting to your alveoli. Breathing deals with exchange. We take O2, we give off CO2. Circulation, every time your heart beats, like in this question, this is a circulation. Severe pain after this type of procedure, realignment, no pulse or weak pulse, that's a circulation problem. Okay? And Maslow is embedded in these things. ABC is part of physical need. Yep. Food, water, warmth, rest. And then you go safety and then the psychosocial stuff. Okay, that's just a reminder of Maslow. And Maslow's right. We talked about Maslow before. Physical needs are necessary to be met for survival. If not, they die. And that's what makes them priority. Okay, so physiological needs have the highest priority and must be met first. And airway, breathing, and circulation fits under that. Oxygen, fluid, nutrition, temperature, elimination, shelter, rest, sex in the sense of reproduction. Okay? We talked about pain. Pain may have physiological component, but reaction to pain is psychosocial. And we talk about the pain that's an exception to this. Just to recap, chest pain, testicular strangulation, strangulated hernias and testicular strangulations, sickle cell, kidney stones, right? We mentioned a whole list of pain. Those are physical because they're killing a body part. And then as you go up Maslow's hierarchy, you get safety and security, which is both physical and psychosocial. MI is a physical need. But sadness, emotional, all of those are psychosocial needs. Usually under safety and security, you're doing a lot of teaching because we want to prevent, right? Very different from physical where you're intervening. So all of that fits under the diagnosis part of the care plan. Now we're going into the third part, which is the planning. Any questions so far? We can't plan until we come up with the problem. We can't come up with the problem until we assess. That's just the way it is. When we when we plan, there's different parts of the plan. There's initial plan, there's ongoing plan, and there's discharge planning. Okay? And then you're going to see how your interdisciplinary team falls under these umbrellas. Because remember, we don't care for the client alone. We care for the client with a whole team of people. But when we're planning is when we're establishing our goals and our outcome. What do we want and how do we want it to happen? So we have to prioritize. We have to come up with a formula for the outcome. We have to select what type of intervention is best to reach this goal. And when we set the goal, we need to set a time frame as to when we want this goal to be accomplished, right? Some goals are going to take a lot longer than others. You can imagine the stuff with airway are going to be taken care of quicker, or we'll want them to be taken care of quicker, or we won't have a client. So your goals must be measurable. That's the NCLEX question. Yeah, you want this wound to heal. By when? Yes, you want Mrs. Jones' airway breathing pattern to improve. By when? Next year, she's dead by then, right? So you have to have a time frame. What's the end? Short term would be hours to days, less than a week. Long term would be more like weeks to months. And those are more for wounds, right? Here's some examples. Adequate oxygen, over 98% by end of 2 weeks. That's long term. Short term, end of shift. You see the difference. But your goal must have a time frame for it to end. So when you're planning and you're identifying your outcome, there are some nursing interventions that you're going to put into play. Now, some interventions are what we call independent interventions. Some are interdependent intervention, and some are dependent. So one more time, independent versus interdependent versus dependent. What's the difference? Independent are interventions you do by yourself. Your nursing judgment says you can do it. There's no order that's needed. Client has edema, you put some pillows underneath their legs to get the fluid to go back to their heart. That's a nursing independent intervention. Interdependent is when you're using your interdisciplinary team. So we're not physical therapists, but if the client needs physical therapy, the physician will be implementing that in there. And it's our job to make sure, let's say they have PTOT, who's coming when, how many times, all of that. Let's say Mrs. Jones needs a respiratory therapist. That would be part of the interdisciplinary team. A speech therapist. The LPNs are part of our interdisciplinary team. If the client has wound that needs dressing change, right? A dependent nursing intervention requires a physician's order to, like medication, obviously. Now, with these different levels of intervention, you do need to think about the interdisciplinary team, because some questions, what they'll do is they'll describe the client to you and ask you what interdisciplinary team would be a part of this patient's care. So PNs will get these questions too, because you do need to know. So the client earlier, where I gave them COPD, I gave them a stroke, I gave them appendectomy, I gave them all. So you would have to look at this client and see all the specialties, all the interdisciplinary team that they would need. Post-stroke, they may need PTOT-ST, COPD, respiratory therapist. You see my point? So you have to be able to tell, okay, what's going on with this client and what team do we need? So when it's time to implement, that's when we delegate this stuff, right? Who does what? But when we plan it with them in there, right? When we implement it is when they put these actions, to work. Do it right, right? And then your last step is the evaluation. Okay, have the goals been met? If not, we may need a new nursing diagnose, right? If they've been met, then we can close them out. Okay, so documentation. Not a heavy area, but a lot of FYI, right? A lot of silly things that I think you've forgotten and you need to keep in mind. You already know that documentation is confidential, okay? If it's not your client, it's not your business. A little acronym we have for you is called COAPS, okay? It needs to be accurate, complete, timely, subjective, and objective data, which we're going to talk about those two. Subjective is what the client says. Objective is what you observe, right? You knew that. Like I said, this is information you already know, just a refresher, okay? So subjective, what the client says. Objective, what you see. Assessment, you're good with that. We drilled that enough. And then you need to plan what you're going to do, okay? So now general charting rules, like silly little things. You want to chart in the correct chart. Only record facts. Your opinion should never be charted. One more time, your opinion should never be charted. So when you get these charting questions, whenever you see your opinion, I think, I believe, no, that cannot be part of your charting. No, it has to be facts, what you observe, what you see, what not, you know, your assessment. And we're going to talk about you not mentioning, do not mention, should be a space here, incident reports. We're going to talk about incident reports. This is an important, that NCLEX question is never going anywhere. They're always going to ask you that question. We're going to talk about that in a moment. You know, Joint Commission has changed the whole abbreviation thing. Avoid abbreviations. We spell things out. No more QD. Tell me every day. Tell me every other day. Tell me telephone order. You know, we don't alter records. If we make a mistake, we cross it out and we initial, but now everything is electronic, right? So you can't go back in time. It records automatically when you go in there, the date and the time, right? So if you need to change something, you're just gonna have to write, you know, yesterday, this is what happened, but this is what really, you know, like back in the day, we were able to cross and put, no. And then if you're talking handwritten records too, the proper way is to cross it out, put your initials, and once you're done documenting as well, the way you close a record is one line and your initials. So that means everything after that is not you, okay? These questions are gonna go away because again, everything is electronic, okay? We don't leave blank spaces because anybody can come after you and do that, okay? We don't copy anything without permission, and we do mean permission in writing. All right, incident report. So you walk into the room, you find Mrs. Jones on the floor, right? You will do an incident report because that's an incident. There's a lot of things that happen where you need to do an incident, okay? Anything that's outside of the norm, or things like your colleagues stealing the client medication, you have a client missing from the unit, like certain things abnormal outside of the norm, you need an incident report for. So an incident report is an internal documentation. It's for us in-house. It's like, you know, like it's a family thing. The public doesn't need to know about it. It's for us to fix our mistakes, right? So it is an internal institutional document. It is not part of the client's chart. I repeat, it is not part of the client's chart. That's one NCLEX question. Here's another one. Never, ever, 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 ever document in your nursing notes that you did an incident report. Never reference that. Why? You know, I'm going to ask you why. You need to ask me why. That's how we build critical thinking and know the reason. Because if Mrs. Jones decides to sue Hospital ABC and you wrote that you did an incident report, that attorney can now subpoena, request that incident report. Okay, so we never reference that in our nursing notes. Now, what you do in your unit may not be that, but that's what the book says. You remember, those of you who have experience, go by the book. Those of you who have experience, go by the book. Your experience sometimes hurts you, because I've heard so many students tell me, well, no, my floor, we put it in the nurse's chart. No, that's wrong. It should be in a separate folder binder that does not get broken down with the chart. Okay? File an incident report anytime an incident event occurred that is not within institutional guidelines or the practice of nursing medicine. They do not get done to tattletale. They're to tell us what to fix. Okay. They alert administration, facility, insurance companies of potential claims, but they're not for you to tell. That's another way your opinion stays out of it too. Here's an example of documentation, since we're talking about that section. A child with an abdominal pain is brought to the emergency room by the parents. The parents state that the child fell down the stairs. On examination, the nurse finds several blisters around the child's buttocks. Which statement most appropriately reflects how the nurse should document these findings? So this question is to test that you know how to document, leaving your opinion out of there, documenting only what you observe, right? All this stuff we just talked about. So you find several blistered areas on the child's buttocks. How do you document that? 1, 6 areas of 1 centimeter diameter reddened, moist blisters, areas noted on the buttocks. Those of you who want to hold on to that, let's see. Number 2, multiple small burn marks. You don't know that they are burn marks. That is your opinion. Throw it away. 3, blisters and reddened skin noted on buttocks due to unknown cause. Okay. Several areas that appear to be cigarette burn. Do you know that? You don't know that. That would be your opinion, right? Throw some answers at me. Let me refresh this one. So between 1 and 3, which is more detailed and yes, 1. I see some answers coming at me. So blisters and reddened skin, there's no opinion here. Unknown cause, that's right. We don't know the cause. But this one, he or she measured it. Okay, and there's no opinion here. So these are all objective. So that's your best answer there, number 1. Let's try another one. The nurse enters the client room and finds the client sitting on the floor crying. The client states, I fell out of bed and my hip hurts. How would the nurse document this incident? 1, client fell out of bed and is complaining of hip pain. 2, client fractured hip after falling out of bed. How do we know that? Huh. Okay. 3, client found on floor crying, stating, I fell out of bed and my hip hurts. 4, client hurt her hip when she fell out of bed. How do you document that? The nurse enters the client's room and finds the nurse sitting on the floor. So which statement here says that? Number 1 said she fell out. So you're going to get rid of that because you don't know that. You find the client sitting on the floor. The client states, yes, 3. You found her on the floor, crying, stating. The others are not part of what you were given. So often you'll see your answers in your questions. These type of questions, the answers are in the questions. Yep. Same thing with the last question we just saw. The answers were in the question. So this is how they would phrase these. All right, this one is just to remind you that the Joint Commission have this whole do not use list of abbreviations, but it's just a good habit to not abbreviate, period. Especially if you have horrible handwriting. All right. Types of laws. This is an important topic too. Not as important as priority or delegation, but important. All right. Types of laws. There's criminal law versus civil law. They're different. So criminal law is intentional harm. Intentional mean you planned it, you meant it, you worked it out, you intentionally wanted to hurt someone. That is a felony or a misdemeanor. Bad. You know, here in the United States, our laws is like innocent until proven guilty. Other countries are different, but your test is based on the United States laws, so you can go by that. Yeah, other countries are different from that, but that's how we are here. You are innocent until proven guilty, okay? Now, whoever's suing you, right, it is their burden. They have to prove beyond a reasonable doubt, that's how we are here in this country, that, you know, you intentionally meant to harm them. That's criminal law. Civil law is different. Civil law is more a dispute between two parties, or what we would call a negligent, you made a mistake. That is unintentional. That's the big difference between the two. Criminal is intentional. Civil is unintentional. Okay? Or sometimes you'll hear the words quasi-intentional or intentional torts. As professionals, we fall under this umbrella, right? Where if a person is negligent, which is if we were talking to each other layman's term, we would use the word mistake, right? You're in a mistake, or oops. That's layman's term. You're not going to see those words on it. You're going to see negligent, okay? So negligence or malpractice are examples of unintentional tort, okay? So let's talk more about that. So these are definitions you need to be familiar with, okay? You need to be familiar with negligence, okay? Let's see if the red is better. Nope. You need to be familiar with malpractice. Oops, correct. Okay, I better stop messing with this stuff. You need to be familiar with these definitions. So negligent is when you make a mistake, layman's term, but medical breach of duty. You broke a promise, okay? And we're going to talk about some ethical principles that you need to know their definitions. They're coming up. You're going to have to spend a moment with these vocabulary words and learn their meaning, because they're what we call ethical principles. You promise these things. Once you get your RN license, you're working for a facility, or PN license, any license, PN, RN, nurse practitioner, whatever it is, you promise these ethical principles. So when you break these promises, sometimes clients end up getting hurt. Malpractice is professional negligence. So negligence is the breach of duty that you promised through your ethical principles. Malpractice is professional negligence. The unintentional, you didn't mean it, failure of an individual to perform or not perform. Now, commission versus omission. Okay, because sometimes we hurt a client because of something we did, but sometimes we hurt a client because of something we didn't do, but we should have done. I'm going to give you examples. Don't worry. So, a couple of questions. A nurse accidentally administers a drug to the wrong client, leading to a drug reaction. That's a oops, right? My bad. The action could lead to charges of, is that tort, malpractice, fraud, or assault? Talk to me. Based on what we just talked about and just learned, you made a mistake and give the wrong drug to the wrong client. You're going to get charged with tort, malpractice, fraud, or assault. Let me refresh. My computer is full. That's why that keeps coming up. And I have to get rid of it. All right. Those of you who say two, I think, yeah, two, yeah. That's a malpractice. Occurs when the form of negligent, oops, my bad, it's not on purpose, causes injury to the client. Let's read the rest. It is the failure to act as a reasonable person with the same knowledge and experience would do. And that's what they do. When you get sued, they bring into court somebody who you'll see the terms reasonably prudent. You'll see those words. a reasonably prudent person with the same knowledge and experience, and they say, okay, here's the situation. Okay, what would you have done? A tort is a wrong or injury that a person has suffered from another person's action. So the tort is the injury, is the wrong or the injury itself. The malpractice is a charge. You know what fraud and assault is. Okay, so that's how they would phrase that. Now, there's a couple more things under that umbrella you need to know. Negligence involves 4 legal concepts. So in order for you to be found guilty of negligence, 4 things need to exist, or else you cannot be sued. They can try, but if you have a good lawyer, you should be fine. So number 1, if you're going to sue me for negligence, let's make somebody else. You're going to sue Nurse Susie. Hopefully nobody on this line is called Susie. If you're going to sue Nurse Susie for negligence, number 1, Nurse Susie needs to have been your nurse. You see here, duty. You can't sue me unless I had a duty to care for you. Nurses have a legal obligation to provide nursing care to clients and must meet a reasonable and prudent standard of care under the circumstances. So let's bring this into NCLEX world. You at Publix shopping, and somebody walks up to you and says, oh my God, my head is pounding. Do you have anything? And you give them some aspirin, right? And they bleed to death. Can they sue you? No. Why? Because you weren't their nurse. Same thing with the question with the neighbor. The neighbor knocks on your door, same scenario. I have a headache, blah, 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 and then you give them something and they die. I don't know if you didn't die from something else, but anyway, you weren't my patient. That's the whole point of this. There needs to be some type of duty and responsibility. Next, breach of duty. Failure to provide expected reasonable standard of care under the circumstances, including omission and commission. That includes something you did or didn't do. So you broke that promise, right? Example, NCLEX example. This is a true NCLEX question, which I think is a nice one, but they've been throwing it at you for years and it's probably not gonna go anywhere. So they tell you the client is going for a GI study and the physician orders a barium enema. And the nurse didn't check for that white clay colored stool, and the enema hardens in the client's GI tract and perforates it, and the client dies. Now that is negligence of omission. The client didn't die because of something the nurse did that harmed them. The client died of something the nurse should have done but did not do that harmed them. Am I making sense, everybody? Talk to me. Am I making sense? That would be omission. So you see, it's not just sometimes stuff you do, it's stuff you didn't do but should have done. And talk to me. Did that make sense? Another one is, I just realized this has one. Another one is proximate cause. So proximate cause, in order for somebody to sue you, the nurse, they have to prove. Now let me repeat that. They have to prove, okay, that what you did or did not do, omission or commission, is what harmed them. They have to prove the relationship between the breach of duty and your injuries. Because how do I know you're suing me because you bled to death? How do I know it's not something else you took that caused you to bleed to death? You have to prove that what I did or didn't do, right? The injured party must prove this, not you, the nurse. And then lastly, damages have to exist. The injury and the monetary award of the plaintiff. So in other words, in NCLEX world, you can't sue for emotional, right? You have to have some type of physical. harm. But these 4 things must exist. Try this question, 30 seconds. Send me some answers. Let me refresh. There's a keyword here. My first answer is not correct. Anybody else? Throw some answers. So here's your keyword here. It's your next door neighbor who is a nurse, but they're not your nurse. So what's missing? Edlin, yes. Duty owed is what's missing, folks. That was not your nurse. They complained to the next door neighbor, a nurse, about the headache. And they took the aspirin offered by the nurse, but not their nurse. Everybody sees that? So it's number 2. Duty owed. There was no duty here. I wasn't your nurse. I'm your next door neighbor. So this did not exist. There might have been some injuries, and I don't know if it's due to the aspirin. It could be, but this did not exist. Everybody sees that? Great question. All right, next topic. Report. We are mandated by law. The law says we must report client conditions, certain client conditions. For example, you know, we are advocates for the young, the old, the mentally ill, the disabled, right? We're advocates for them. So anytime we're sensing any type of abuse, neglect, we're advocates. Communicable diseases, you work on an infectious disease and a client is admitted with tuberculosis, you're picking up the phone, you're calling the CDC. You are a nurse working in the emergency room and a client comes with a gunshot wound, you're calling the authorities, right? We're mandated by law. If a client threatens, as soon as I leave this hospital, I'm gonna do this, and this to that person, you've got to intervene. And we are also mandated to report unsafe practice of healthcare personnel. So you have a colleague who comes to work impaired, you are mandated by law to report that colleague. You cannot allow them to care for a client while impaired. Priority is to remove them from client care because it's not safe for you to care for a client if you are impaired. Okay, all of this stuff we're talking about, okay, with the law and the reporting and all of that, those are part of standards of care. And we talked about at the very beginning that once you're following your standard of care that your facility has in place, you should avoid getting sued. You avoid negligence. Okay, so follow your standard of care, use ethical guidelines that will help you solve ethical dilemmas. An effective leader modifies his or her style. I told you that whoever can change their style to accommodate the situation is the best leader. Learn to delegate properly. Okay. Which action, if performed by a nurse on an acute care setting, are considered professionally negligent? Select all that apply. And remember, we love select all that applies. You see, I've thrown a few at you already. Okay, and you're gonna see me do that frequently. And it's not to traumatize you, it's to just better prepare you when you see them on the real NCLEX. We can't do all these, sessions and stuff together without select all that applies. You're going to see me throw some at you every time we meet. Okay? Which action, if performed by a nurse in an acute care setting, are considered professionally negligent? So let's go down the list. Remember, with select all that apply, yes, no, apply, doesn't apply. That's how we treat them, right? True, false. The nurse is injecting heparin and does not aspirate. Do we need to aspirate with heparin? Talk to me. I know there's like a 30-second lag. Is heparin sub-Q or IM? And remember, now the CDC put out those rules about not having to aspirate anymore with IM injections, right? But I don't believe your NCLEX has moved on from that, so you do still need to keep that in mind. So no, we don't need to aspirate. So that's fine. Okay, see, I had to go back to my question and say, am I looking for something good or something bad? Considered professionally like negligence. So I'm looking for bad stuff. But did everybody see that? I literally had to stop and say to myself, am I looking for good? Because after I read this question and I decided, okay, we don't need to aspirate for heparin injection. But then I'm like, am I looking for good stuff or bad stuff? Correct or incorrect stuff. So I had to go back to my STEM. And this question is a one sentence question. So literally, so those are test taking strategies. So as I sit there, I'm looking, what am I looking for? So go back to your STEM and say, and the keyword is right here, considered professionally negligent. So I'm going to throw away one. The nurse verifies the client by asking him or her to say their name, then give the medication. Okay, so now we need at least two, right? Form of verification. So this is negligent. Hold on to it, right? We need two forms. So hold on to number two. That's negligent to only go by their name. What if you have two Mrs. Jones on the unit? Okay, so number two is negligent. Number three, I see some answers if you didn't choose number two. Okay, number three, the nurse assesses the circulation of a client's extremity every 30 minutes while the client is in a wrist restraint. Okay. Number four, the nurse completes the first fall risk assessment 12 hours after a client is admitted to the hospital. 12 hours is too long. Remember, I told you that whenever you see time, like I just saw the 30 minutes, I'm like, okay, that's fine. And then now I'm seeing 12 hours. 12 hours is too long. That assessment needs to be done on admission. And 12 hours later, yeah, that's too long. That is negligent. Okay, by then they failed 12 times. Hold on to number four. Number 5, the nurse requests a nursing assisted personnel suction the nasotracheal tube for a client who is comatose. So nursing assistant outside of their scope, right? 5. All right, so we've got 2, 4, and 5. Most of you say 4 and 5. You forgot 2. You need 2 forms of ID, not just the name, but close. All right. The impaired nurse, that's another important topic. I mentioned it earlier. We're going to go a little detail in here. You cannot allow anybody who's impaired to care for a client. Okay. So your priority, the first thing, the best thing, the initial thing is to remove them from their client. Okay. They're compromising clients' care, and it is our job to make sure clients are safe. Okay, but be sure they are impaired before you accuse them of that. You want to climb up the chain with this. Your nurse manager, risk manager needs to know. You're going to do an incident report. This is an incident. Okay, we need to follow institutional policy with this type of stuff, but priority, client safety. There are some legal stuff we're going to talk about, okay? And some of it we've already covered, but we need to talk about advanced directives under this umbrella, restraints under this umbrella, informed consent. So these are some things that are coming up. They fall under the legal responsibilities. So legal and ethical issues. So under that is HIPAA, right? Principle of confidentiality. The law governs us in this area, right? Guides us and shapes us and kind of pretty much tells us what we can and cannot do. Under this area, federal law regarding chemical dependence, confidentiality, psychiatric, HIV, all of that falls under this umbrella. We, healthcare providers, cannot disclose any of that unless the court mandates it, right? Of course, that's different. If the court mandates it, that's just the court. So we have to give it. But for the most part, no, we don't give it. State law governs us regarding HIV testing. You cannot do this test without special consent. Okay, the admission consent is not good enough. There has to be a separate consent concerning HIV. And even how it's disclosed to, certain states have different rules with that, but the states have laws regarding when HIV test results or diagnosis of AIDS may be disclosed. So for example, even with spouses, let's say you work in infectious disease and a client is admitted and they've been diagnosed with HIV, the physician cannot tell the spouse, which you probably have an opinion about because it's a touchy subject. And it's so if the spouse chooses, if the client, your client chooses not to tell their spouse, you can't make them, and you can't go over them and tell the spouse either. I know there's like a whole touchy area with this one. All right, so legal and ethical issues. Back to HIPAA. So HIPAA is big under this umbrella, right? Health and Insurance Portability and Accountability Act. So what that does is it ensures and protect the client's information, okay? If a client wants information disclosed to whomever, they have to give you permission in writing, okay? And again, it has to be in writing. If you're not part of the client's care, you need it in writing. So here are the rules. Confidential information may only be released by signed consent of the client. So that's the in writing part, okay? There's questions where they tell you the family member, the next door neighbor, whoever it is asking about the client. The law prohibits you, period. There's no ands, ifs, or buts, okay? The only time this rule doesn't apply, as I mentioned earlier, is if the court requests it, okay? So like if it's a child abuse case, communicable diseases, the rules are special for that. Those counts the rules, okay? Mental health clients also fall under this umbrella. You see right here, special regulations apply to release of information about psychiatric illness or HIV. We already talked about the HIV part. Psychiatric illness, yes. So, you know, especially with a psychiatrist and everything, your information is protected, where they cannot share that information unless you threaten to harm someone. Then they have the ability to warn that person, right? And these rules came into play for a reason, people. Folks didn't just wake up and make up these rules. This ended up happening. These rules came to play because there's cases where, you know, in the past, clients' information used to be protected 100%. Like the psychiatrist couldn't really reveal anything until somebody threatened someone and they went and did it. So now, of course, these rules change, where the psychiatrist can say something and warn that individual. So sometimes you wonder, how did that come into play? You know, like with, I'll give you another really good example. With restraints, you wonder, why can't there be a PRN restraint to order to restrain someone? Because people in the past got tied up, locked up, drugged up, and forgotten. So you have to wonder, why do we have these rules? Because something happened in the past that caused it. You know, as I work with students in schools, when I was directing programs, I would tell students, always ask me why. So for example, when we change exams, like there was a school where the exam was compromised. They were using ATI and the students had all of the ATI exams, version A, version B, all of it. And so then they changed from using ATI to using Kaplan. And they were like, so I said, ask me why. Ask me why, you know, the change, because people have ruined it for you. So whenever you see changes in policy and procedures, somebody did something. A nurse receives a call from a client's son who is requesting specific information about the client's diagnosis for insurance purposes. How should the nurse respond to the client's son? Now that should be an easy one, right? So 10 seconds. Yeah, very interesting. Let me refresh this. Throw some answers at me. We read it together, so you should need even less time. Are you giving it? You're not giving any information. Perfect. 3, privacy regulations preclude me from disclosing information about your client, about our client, about your mother. Absolutely, you're not doing it, and you don't need to be rude about it either. You know, number 2 is just rude. Client's rights. All right. Recognize the client's rights to refuse treatment and procedure. Yes, they're awake, alert, oriented times a gazillion. And they refuse. Your job is to give them the facts, right? Even sometimes, you know, we refrain from being so blunt, like, well, if you don't take this, you're going to die. Like, you don't want to come out and say that. You want to say, okay, listen, your HNH is that. This is what could possibly happen. You have to choose your words. But they refuse. They have the right to refuse. Discuss treatment options, decisions with the client. They have the right for you to provide education, right? They have all of these rights. Okay, and we're advocates for them. Okay. Right before cardiac catheterization, the client says to the nurse, I do not want this procedure. Which response by the nurse is best? So here's how they would phrase this. 1, the consent is already signed. I'm not sure you can change your mind. Do not be concerned. Never choose answers like that because the concern is real. Okay? You're dismissing their true feeling and emotion. They're concerned. You can't just tell people don't be concerned. You could have done this procedure a million times. I don't know. You're not focusing today. Maybe you just got into an argument with your spouse. I don't know. 3, I'll call the cardiac catheterization lab to cancel the procedure. Yes, you will. What are your concerns? You do number 4 as well. But before that, you're canceling this procedure. They don't want it anymore. But I do want to know what your concerns are. Yep, we're going to address that. No. Cancel the procedure. I do not want this procedure. Yes, I do want to know their concerns. I see most of you are saying 444. Yep, you do. What are your concerns about the cardiac catheterization? Yep. But their concerns are real. You're gonna cancel. You may bring it back together once you talk to them. Okay, listen, I had somebody, I don't know, they had somebody who they know who this didn't go well. I don't know, whatever their concerns are. Let me ask you something. Chime with me. If you already medicated them and they change their mind, what do you do at that point? If you've already given them some medication, you've already given them pain medication, sedative medication, you drug them up. What happens with this question if you've already drugged them up? Talk to me. It's too late by then, right? I'm not seeing any answers. Isn't it too late by then if you've already drugged them? Now, let's say, here's another question, which we're going to talk about, consent. So I know in this scenario, okay, you're about to do the procedure, they've given you consent, but let's say we change this question and you realize that you don't have consent. Can you do the drug? Too late because they are not, exactly, they're not awake, alert oriented. Yes. Okay, when we do mental health, I'm gonna go under therapeutic response and all of that, but that's another way I could change this question because that is a concern that is valid, yeah. And we have to take that into consideration, but dismissing it is not good. So there's so many things I could do with this question and change it around, but we're also gonna talk about consent. Yeah, for PNs, consult the nurse supervisor, absolutely. We're gonna get into consent a little bit and you're gonna see these intertwine a little bit. All right, advanced directives. So this is another section, don't mix something we're gonna talk about. Okay, so in 1990, the Omnibus Budget Reconciliation Act, short OBRA. OBRA came into play in 1990. So under OBRA says if you admit a client, even outpatient folks, you need to find out if they have any advanced directives, right? And if they do, you need a copy in the chart, right? And if they don't and they want to start one by law, according to OBRA, we have to provide them the document to start one, okay? All of this falls under umbrella. Okay, so now, living will. So living will is the client putting in writing what they want done, what their wishes are. Do they want to be intubated? Do they want full CPR done? Like, you know, do they want feet? Like, what do they want? But it's in writing. Durable power of attorney is them choosing a person to speak for them as to what they want. That person will make all the decisions. This is the thing with these two. Living wills and durable power of attorney, healthcare surrogate is the same thing. Those two do not come into effect unless the client is mentally gone. They are incapable of making these decisions. Because as long as they're awake, alert, oriented, they can tell you what they want. They can decide, they can say, right? So the living will doesn't go into effect until they're mentally incapable. The durable power of attorney, whoever you chose, do not go into effect until, okay, they can't make their decisions. Now, number 3, do not resuscitate, DNR. This one is different. When a client is a DNR, first of all, they have to have an incurable disease, right? Something that there's no cure for. Number 2, the physician has to assess them and find them to have a certain period of time to live. And some physicians will give them, let's say, you know, based on what you have and history, research, all of that, you have 6 months to live, right? So now the client and the physician or family member, whoever puts this DNR together, right? It's at the bedside, it's in the chart, everybody knows it. Some people are even tattooing "do not resuscitate" on their bodies, right? Can't get any more permanent than that. So now, NCLEX. First of all, if you attempt to do a CPR on a DNR client, that's battery, okay? You could lose your license. Number 2, let's say Mrs. Jones is dying of cancer, right? But she's awake, alert, oriented. And then she changes her mind. You see how earlier we practiced that question where the client changes their mind and they change their mind? Like, you change your mind. So that's what NCLEX is testing to make sure that you know. If this client changes their mind, they're awake, alert, oriented, then verbally they null the DNR. That's the NCLEX question. They null the DNR verbally. So you as the nurse, you take the chart, Mrs. Jones, quote, quote, "I don't want to be a DNR anymore," whatever she says. And then you call the physician, you let them know, of course. But my point is, and your NCLEX question is, it knows it. Just like, I don't want this surgery anymore. It's not my job to convince you to have it. It's not my job to force you to have it. My job is to give you the facts. You're awake, alert, oriented? Yeah. They have the autonomy to make their own decisions. So don't get these questions wrong. You can verbally, okay? Same thing with the surgery. Until I drug you, you can change your mind. Okay. So we're talking about, go back right here. We're talking about advanced directives, living will, durable poverty, DNRs, right? So only, here's an only, you know how we feel about that word only. Only, okay, the only employee of a healthcare organization who may be the legal witness to signing of an advanced directive is the social worker, okay? And that is, you're like, why, right? Why? I need a buzzer that says why. Because we healthcare providers tend to benefit from, living wills and such. So that's why we can't witness them. If you're going to benefit from it, you can't witness it, right? Especially in this day and age. Okay. The nurse's role in informed consent. Okay. So not advanced directives, informed consent, very different. Ladies and gentlemen, do not mix advanced directives with informed consents. Very different. So we're done with advanced directives. That's the living will, the durable, the DNR. Now, informed consent is what it says. You're giving me permission to do something, right? So our role, our job, the nurse, is to ID appropriate person. So making sure that Mrs. Jones is Mrs. Jones. Mrs. Jones knows what she's signing. Mrs. Jones is of age, right? That's our job. Okay, we're the advocate. We're protecting their rights and dignity. We're identifying any fears. Let's go NCLEX here. It is the job. It is the job. It is the job and responsibility of the physician to explain the procedure or the surgery, not the RN or the PN. One more time. We would be outside of our scope of practice if we're doing the initial explanation of the procedure. The physician has to go in and say, listen, Mrs. Jones, tomorrow you're going to have open heart surgery. Here are the pros to this and here are the cons to this. Do you have any questions? We can come after the physician and reinforce. So you have to see keywords like that, right? If you're getting the sense in the question, you're doing the initial explanation. Same thing, PNs. The RN has to have done the initial teaching for the diabetic. You are reinforcing what the RN has already done. RNs, we're reinforcing what the physician. Remember my ladder? Yep, that's just the way it is. The nurse may assign the task, maybe assign the task to obtain and witnessing the signature. That's all we're doing. You're Mrs. Jones, you understand what's going to happen, and you're signing. So if you find out Mrs. Jones has no clue, no idea, nothing, the physician needs to come back. Okay, and that's the answer to that question. I know in real life it's different, but they're coming back. Consent laws. So what is the law concerning consent with age? Who can give consent? You know those questions are floating around. So first of all, in order to give consent, you need to be alert, coherent, competent. We talked about that. Some of you sent stuff earlier, questions or comments. Here, consent of minor clients 14 or older must come into agreement with their parents. They're not adults. Nope. Now, if they're pregnant, that changes everything, right? You want to make a decision, get pregnant. But that is what it is. I'm just here to give you the facts, okay? Don't, like, there's no opinion in here. Like, I don't care. I teach by the book, okay? So pregnant minors, yep, they can give consent for themselves and the baby, but they're still a minor, yes. Competent, emancipated minors can consent for treatment without the consent of parents or guardian. What does that mean? The court says a minor is an adult. That's what emancipation is. Even though they're 16, the court says they're an adult. They don't even go through the pediatric ER anymore. I remember when I did pediatric ER, we've had a couple of, emancipated. We send them to the adult side. They're not a child. They can't come through that ER. Yep. So just remember the rules. Again, I'm just a messenger. Okay. I know this one is another one where you're like, what? All right. The Good Samaritan Act, we talked a little bit about that. Good Samaritan laws are state statutes intended to protect individuals, the public, from legal liability for providing medical assistance to injured person in emergency situations. So there's an emergency, you have the experience to save that life, save the life. You're protected. But stay within your scope of practice. If you are outside of what you're trained to do, you could be sued or liable. So you're protected as long as you stay within your scope. A nurse stops to assist a man on the street who is having a seizure. Despite the nurse's assistance, the man dies. Protection from liability is provided the nurse by the Good Samaritan Act. That's all. The Nurse Practice Act is not what's in play here. The ANA code nope, it's the Good Samaritan because she's driving down the street. Yep, a man is on the street. Okay. Restraint falls under this umbrella. We'll talk about restraint again under mental health, but it falls here in the sense of safety, not so much safety, but nursing responsibility. Okay. So the nurse must document. Why do we need a restraint? First of all, restraint is a last measure. We talked about that little test-taking strategy you need to keep in mind. Remember, we're least restrictive before we're most restrictive. And this would be most, right? Because before you restrain someone, you need to reorient them to person, place, and time. It could just be from confusion. You need to put them next to the nurse's station. You need to get a one-to-one sitter. Like, there's so much you do prior to this. This is in case this is an emergency, they get, violent. And all right, so why? Okay. How are they responding? You saw the question earlier. They're on a wrist restraint. I'm checking for pulse frequently, like every 30 minutes type of thing. I'm releasing them, range of motion. Okay. How are they responding? Now, if I need to continue this restraint past 24 hours, I need a new order. So let's go over how restraints work. So Mrs. Jones gets physical, I need to restrain her, right? It's an emergency, you restrain her. And then the moment you're done restraining her, let's say you put her on a posy vest, right? You have to go pick up the phone and call the physician and say, listen, Mrs. Jones got aggressive. We had to restrain her. May I please have an order for a posy vest? You want to start least before you go, Because you see the posy vest is this one right here. It doesn't hinder her from moving her arm or her legs or anything. So it's not as restrictive as the wrist and ankle. And of course, some of these are very like, really, the client is all tied down. And I would hate to not be able to move my hands. That kind of messes with my head, but that's me. So after you pick up the phone, you get the restraint. 24 hours later, it automatically expires. That is one order. You can never, ever have a standing order, a PRN order when you need it. No, it doesn't exist. It used to be that way, but that has changed because, again, you want, why, right? Why? Because somebody tied up, drugged up, locked up people. Others did that in the past and forgot them, and they died. So you can't do that anymore. The moment you got the order, that date and time, it expires 24 hours later. No PRN order to restrain. NCLEX questions right here. There can be no standing order. Okay, we only use it in case of an emergency. The physician has 1 hour to come sign this. Okay, they have 1 hour to evaluate this client. Again, some of you work in psych units and you know this doesn't happen in an hour. So please go by the book, right? Oh my goodness. Yes, please go by the book. Because this is just one of those areas that's not going by the book. Okay. Seclusions within 1 hour, medical restraints within 24 hours. Again, it's whenever they get there. You know this, we're gonna do least before we do most. That's embedded in your brain. You must document you tried other measures, right? Yep, there has to be some documentation of reorienting, all of that lovely stuff. Okay, restraint should be released periodically in the skin. Once you put, physical restraint, skin is a priority. Okay, for those, we'll go into those details when we cover restraint with the quick release time, right? And we want the restraint tied to the bed frame. Why? Because the bed frame does not move, the side rails move. So if you tie a restraint on the side rails and I bring the side rails down, you make those restraints tighter, right? You could choke the client. So those are the silly little things you need to remember concerning restraint. Here's an example question. And you're so excited because it's a select all that apply. I can feel it. Oh, you're like, no, thank God she's almost done. Okay, wake up. So the healthcare provider writes an order of posy vest restraint. I put a picture there for you because I know there's so many different types of restraint. You may have forgotten what that one looks like. You see how with the posy vest, she can move her arms, okay? The client is diagnosed with altered mental status and a UTI. The nurse determines that care is appropriate. So as I read that, I tell myself, I'm looking for good stuff, if which is observed. I'm looking for good stuff, appropriate stuff, correct stuff, and it's a select all that apply. All right, 1, the staff nurse performs every aspect of the client's care. Now, that's not necessarily a good thing, every aspect. So we want them to do something that they can do, right? Because then you're going to hinder them being able to get better. You don't want to do everything for these clients, okay? Number 2, the staff assists the client to the toilet or commode every 2 hours, okay? I see time and I'm processing, is 2 hours appropriate for this? Yes. Awesome, hold on to that. The staff secures the restraint with a quick release tie to the frame of the bed. Awesome. It's a quick release and it's to the frame right here, not the side rails. Hold on to that. The nurse requests that the healthcare provider change the order to extremity restraints. Why? What would be the rationale behind that? You would freak them out more because they can't move their arms now. Okay. Number 5. The nurse obtains consent from the client to apply the restraint. What client who's altered mental status, diagnosed with altered mental status, is going to give you consent? No, they're not going to give you consent. And who's going to give you consent to tie them up? Not me. My daughter's laughing. The nurse reorients the client every 2 hours. Awesome. All right. So which ones did we keep? 2, 3, and 6. Yeah, 4 would not have helped. What was 5? They're not going to give you consent. Okay, and 6. I see 2, 3. Okay, 4, no, don't keep 4, because 4 is more restrictive and it's not necessary. Now, if I get a question, well, let's say in this question I add the client has a Foley catheter and they're trying to pull it out. Yeah, then that might make sense. Right? Then let me show you something. Then I may want to get something like a posy finger control, right? Because then they wouldn't be able to pull the restraint out at that point. So then I want to take a look and see when I would need such a restraint. Because again, that would freak me out if I can't move my hand. All right, so remember earlier I mentioned there are some ethical principles that you need to know and memorize and know their definition of. Here they are. Ethical principles says you respect others, and you do, right? As a nurse, as a healthcare provider, you do. And this is some of the things we try and teach students, because I work at schools where we don't just teach students how to become nurses. Some schools that I've worked with in preparation for students, I've seen some behaviors that I'm like, ooh, you're in the wrong profession, because you have to know and build some ethical principles that show respect. And if you're not showing respect to your classmates, your instructor, your administrative team, your whoever, how are you going to show respect to a stranger? And that's what I always tell students. Like recently, these 2 students got expelled from a school because they were arguing with each other, where it got, profanity, went to the parking lot, just madness. So unprofessional. So folks have to learn to walk away. No matter what people say, and what somebody says shouldn't cause a reaction in you. So this is a higher level, of professionalism where students are going into, and I don't blame the school because they have zero tolerance for stuff like that. So both students were expelled, but one student was like, well, I was just reacting to them accusing me of cheating and all of that. It's like, okay, yeah, as an adult, you need to build some very high level of professionalism, and your ethical principles fit, mold and shapes that. You have to have respect for others. So autonomy is respecting the client's right. So they have the right to decline. You saw care. They have that right. Non-maleficent means you promise not to harm them. You do. Beneficent means you promise to do good and avoid bad, right? Justice, that one. You promise to be fair. Veracity, the ethical duty to tell the truth. Don't lie to your clients, especially in the pediatric setting. Don't we lie to children, which is terrible. It's not gonna hurt, and it hurts. So don't do that, because what happens is they don't trust you anymore, right? So veracity, confidentiality, we talked about HIPAA, right? Keep my business, my business. And I can tell you real life examples after examples after examples. During the time when Anna Nicole passed away, I worked for Memorial, and so many people got fired. And I remember another incident when, what's his name again? Dwayne Johnson was hospitalized at Memorial, and a whole lot of people went in his chart. They went in Anna Nicole's chart. They go into these celebrity charts, and they have no business. They weren't the nurse caring for these celebrities. That's a big no-no. And everything is now, password and, your nursing ID and everything. So they know who went in these charts. I've even many years ago, actually twice, received letters from the healthcare system saying somebody, went into my file, didn't have permission to do so. And then right after that, my identity was stolen. So, and when they investigated, it was some guy in Davie and whose identity was stolen. So it was like a whole domino effect. It wasn't him, but somebody was acting like it was, because he reported his identity stolen as well. So then they give you this whole credit monitoring for however many years because somebody went into your chart and has your social, and then they file their taxes they filed taxes under my social before I could file taxes under my social. So it's stuff like that where, had these records been protected properly or people didn't do stupidity that way, none of that would need to happen. But I've been a victim of that twice. Fidelity, loyalty, you promise to be faithful, right? So there's a nice question, a real NCLEX question too, that I throw at you, and I know it's floating on the real NCLEX, where they tell you the nurse is caring for a client and the client says, what is this, procedure for? And the nurse says, well, or this medication or something. The nurse says, well, I don't know, let me find out. And then it tells you when the nurse comes back, what ethical principle did the nurse practice? So this is one of those where we tell you, answer the question, right? It says when the nurse comes back. So when the nurse comes back, they were loyal. That's fidelity. They kept their promise. They say, I'll find out and I'll come back. And they came back. So these questions come in the sense of scenarios. And then they ask you what ethical principle was practiced. So you have to understand them really well to pick up the ethical principle that's being practiced. But the thing is, with the scenario I just gave you, the nurse practiced quite a few ethical principles. They told the truth, right? That was veracity. I don't know. Let me find out for you, right? So, and they didn't do any harm. That was non-maleficent, right? So other ethical principles were practiced, but I asked you about one of them. But here's another way that they could pose questions from this topic. A client is referred to a surgeon by the general practitioner. After meeting the surgeon, the client decides to find a different surgeon to continue treatment. What ethical principle did the client utilize when changing surgeons and taking action for oneself? So they were referred to one surgeon. They decide to use a different one. So what ethical principle did they practice? Okay, so the general surgeon say, hey, listen, I'm going to refer you to Dr. Joler. And then they go and, to a different one. Like, okay, I hear you. Thank you so much. However, I'm going to do this. Was it beneficent, negligent, the autonomy, or privacy? Right, autonomy. They chose whom they want. They have the right to do that, and we respect that. Okay? All right. And I'm looking to make sure that you're throwing answers at me. Yes, I am. So, and I want you to get used to 1 minute per question. I'm going to put my timer here. And if it's a select all that apply, I will give you 1.5 minutes. Now, what that does is that also tells you if you're a good test taker as far as the time frame, because remember, you don't want to take the entire time. But those run out of time rules and the entire exam rule is out, but you never know when they're going to bring these things back. So we have to practice. All right. A nurse who has been named in a lawsuit can use which of these factors for the best protection in a court of law? So in other words, what is going to protect this nurse from getting sued? Okay, I see a question. So just to clarify, only management care questions in practice and study notes. Yes, because that's the only thing we've covered so far. The way I work is I want to teach you the material, teach you how the questions generate from the material, practice questions with you, and then you reinforce. All you're doing is reinforcing what we've done, okay? You may get a question on something that we didn't cover, but it's gonna be far few in between, and it's gonna be minor stuff, okay? So for the most part, you're back in nursing school. I'm sorry, don't have like a mini anxiety attack. Okay, yes, the correct answer is B. Let's go over it. A nurse, well, you already read the question. Documentation of the specific client record with a focus on the nursing process. Remember, the nursing process guides us and directs us, okay? So when you have time, you're going to go ahead and read the rationale. But for now, we're going to move on. And a lot of it I tell you verbally, and we've already gone over it because time is of the essence, okay? All right. The next one, the physician orders a medication in a dose that is considered toxic. The nurse gives the medication to the client who later suffers a cardiac arrest and dies. Which of the following consequences can the nurse expect? Let me look at my time watch because I'm timing you. Okay, so the number of questions that you do is not really the goal. However, if you're just doing 25 questions, that's not enough, right? But so for example, every area is different. Okay, I'll give you a good example. So I was just working on something for a school, right? And they want to use UWorld. I don't have a problem with using UWorld. So they were asking me to set the number of questions students should practice based on, after every teaching, based on so I have to base that on the categories, because what happens is UWorld, Kaplan, HESI, like all of these standardized programs, they set the number of questions based on the percent from your NCLEX, right? So for example, the higher the percent, the more questions you're gonna get on it, right? So for example, I just took the sheet out for management of care, like management concept. UWorld has 76 questions for the PNs. Assignments and delegation, 62 questions. So looking at the different categories, it differs. So if you were to add up all the systems, that's hundreds of questions: cardio, neuro, endocrine, GI, GU, and stuff like that. But for example, like with mental health, all of psychiatric nursing, they only have, I think, 116 questions or something like that. Plus the medications, another 33. But my point is, don't focus so much on the number of questions you need to do, but focus on doing quality, right? So let's say you only had a chance to do 50 questions on management of care. I'm not going to be upset if you learn from those 50 questions, or when I test you, I see you above benchmark. You see what I'm saying? So don't put a number on yourself. If you have more time, practice more questions, but remediate them. That's the important part. Question, answer, question, answer, question, answer, and learn from them. So students ask that all the time, and it's one of those things where it's individualized. If you're using a Mac with the NCLEX 4000, you do need another program. So let me know if you're using a Mac, okay? All right, I see different answers here. So I see B's and I see C's. So let's go over this one. The answer is B. Let's go over why. The nurse and the doctor can duly be charged with negligence, right? This is a negligent question. So in real life, the physicians get a slap in the hand and nurses loses their license. We get punished severely, but both are liable, okay? The physician that writes the prescription and the nurse that gives it. When we do pharmacology, intro to pharmacology, I'll show you, we'll go a little bit more in depth with you being responsible for what you give, but both are liable, okay? An individual has a seizure while walking down the street. During the seizure, the nurse from the physician's office is noticed driving past without stopping. So we practiced similar questions earlier, but here's another way they can phrase this, right? So individuals having a seizure, the nurse drives by. Everybody knows she's a nurse, she's in her uniform, but she just drives by, did not stop. The individual sues the nurse for negligence, but fails to win a judgment. For which of the following reasons? A, the nurse had no duty to the individual. B, the nurse did what most nurses would do. Isn't that an opinion, right? That's an opinion. Opinions are never correct. Get rid of that. The nurse did not cause the client's injury. the nurse was off duty at the time. So why can't the person win this lawsuit? Or why would they not win this lawsuit? A, thank you. The nurse had no duty. It's true. You weren't my client. It would be nice to stop, but you're not obligated. Okay? The nurse must have a relationship with the client that involves providing care, okay, in order to sue. Okay, and this relationship is usually, I work for facility ABC and you're my client. Otherwise, I don't have to. A client asks why diagnostic test. Oh, there's a question I was talking about earlier. You already know the answer, but at least you get to see how it's phrased. I like this question. A client asks why diagnostic test has been ordered, and the nurse replies, I'm unsure, but I will find out for you. When the nurse later returns and provides an explanation, the nurse is acting under which principle? You see the keyword here? So remember when we were doing test taking strategies and I tell you answer the question. The stem of the question is the part of the question that asks the question, so answer the question. Remember that madness? This is a perfect example of that, because when the nurse later returns, that's your stem. What ethical principle did they follow when they later returned? Oh, I hope that's the answer to the last question. Yeah, so answer this question, everyone, which we talked about earlier. Nobody should get it wrong. If you get it wrong, then that tells me you weren't listening to me, and that's not good. Okay, so when they later return, was it non-maleficent, veracity, beneficence, or fidelity? What did they practice? Fidelity, exactly. When they later returned, they kept their promise. I'm unsure, but I'll find out. Okay? But again, they practice other ethical principles, but you weren't being questioned on those. Now, some of you need to keep this in mind, because sometimes you're between two answers and I tell you, answer your stem. Because sometimes some answers look really good, but they're not answering the stem. You need to answer the question you're being asked. Okay. A female staff nurse on the unit asked the charge nurse to complete the wound care and dressing change on an assigned client because she finds wound care distasteful. The nurse manager would counsel the nurse about which of the following subjects. So you have a female staff nurse delegating to the charge nurse. Can that happen? Or should that happen is a better question. I guess it can, but should it? Talk to me. Should the staff nurse delegate to the charge nurse? Now remember your chain of command. No. That's just rude, number one. But number two, that's reverse delegation, and that is a no-no. Okay, and I can change this question, PN, and say you have a PN nurse delegating to an RN nurse, or you have an AP delegating to the PN. No, that is reverse delegation. Okay, reverse delegation occurs when a person with lower rank delegates to a person with higher rank. Okay, no. It's not, it's not the others. It's not over, under, and complete. It's reverse. And that's not acceptable. You can delegate down. You cannot delegate up. Okay, you're good with that. A nurse is pulled from the emergency department to the medical surgical unit. Which client assignment would be best for the medical surgical unit RN to give to the ED RN? Now, I told you that's a floating question. So with your floating questions, pay attention what type of a nurse they are, because that's how you know who to delegate to them. Okay? So this is an emergency nurse. All right? Emergency room nurse, ED. Let's get rid of that. Do you give them the client experiencing respiratory distress? They can handle it. Yep. Let's see if there's anybody worse than that. A client with BP of 140/90, you'd give them the respiratory, because that's what they do all day in the ER. Client with temperature, nope, the respiratory one first. Dizziness after taking, nope. So you'd want to give the emergency department nurse the respiratory distress client because they should be fine handling that. Okay? Great question. So give them the most unstable. They're an ER nurse. When the nurse is called away to care for another patient, which task for the patient could most appropriately be delegated to the unlicensed assistive personnel? Okay, another delegation question with a UAP. So can the UAP determine the amount of residual for the tube feeding? No. Can they give mouth care? Yes, but they can't assess. That one word, if half of it is wrong, the whole thing is wrong. One more time. If half of it is wrong, the whole thing is wrong. Can they explore how the patient is currently coping with their diagnosis? No. Yeah, you guys are right. Yeah, they can do the bed bath and change the linens. All right, so you're kind of good with those. At the start of the shift, there were only 3 newborns in the nursery. So staffing consisted of 1 RN and 1 LPN. Within 2 hours, 3 more newborns were admitted to the nursery, 1 requiring level 2 care, and the parents of 2 newborns needed discharge teaching so they could go home. The RN was needed for full-time in the level 2 nursery as the newborn was stabilized. What staffing is needed to provide appropriate care in this situation? Now, whenever you get long, lengthy, crazy questions like that, don't let that throw you off. This is a delegation question and nothing more. Okay? So you're going to go through each and you're going to say whether that can happen or not. Okay? Where's my cursor? I need my cursor. The LPN can complete the admission assessment. Is that true? No. We said LPNs cannot do admission assessment. Get rid of it. Don't even read the rest, which we tell you always, but half of it is already wrong. Move on. And unlicensed assistive personnel from the post-op unit can be reassigned to the nursery to do discharge. No, UAPs cannot do discharges. Get rid of it. The RN can complete the admission assessment, okay, while continuing to stabilize the level 2. That's too much. That's too much for one nurse. Mistake is going to happen. Another RN needs to be reassigned to the nursery, yes, to implement the assessment. Yeah, get more help. That's it. Get more help. And this is NCLEX world. They're waiting for you to just tag them in. Okay. Oh, we'll do one more, and then I want to, if you have any other questions, right now is the time, okay? Because we have 2 minutes. The RN is assigned to the postpartum unit. Which task could the RN safely delegate to the beginning student nurse? This is a similar question with the graduate nurse, okay? There's no degree, no license yet, okay? Beginning student nurse. So you have to treat them like an AP. So you need to rephrase this, okay? Ambulate a patient who delivered by C-section 2 days ago, fine. Complete admission, no. Call the physician, no. Verify blood, no. That's how easy that is, okay? So once you get to that point, you're gonna boom, 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 okay? All right, so let's exit out of that.